All right, so just let me know if you can hear me clearly and if the video is okay. Just want to know actually and how you all are doing. I hope so everyone is doing well. So this is our some kind of setup or whatever you say. And yeah, now you can say this is my room for taking the class or studio room, whatever you say, that's fine actually. Okay, and we're going to start today with the class which is related to rheumatology. And for the rheumatology class, I mean, we have given you overview. So I hope so you have seen that overview already. I know some of you are serious and some of you have already get into rheumatology. I mean, the best way is actually if you at least can see some of the pages or some of the points which I told in the overview. Okay, so it's like a brainstorming. I have been doing research with a lot of doctors, medical students and the things. So these are some of the, ways and the tricks which is very useful. There's a two group of doctor. Whenever I give everything, they follow it very well, and the results is tremendous for them always. We do have very good passing rate and the thing, but one thing I want to make sure here that there's a one group of doctor, those follow me really well. They able to, appear in the exam in exactly the time they want, like say 6 months or the 7 month. But those are not following. They usually always start the class when Sunday class is done. They're not following well. There's a lot of exams they're not taking. They actually cannot take in the exam in just 6 months, to be honest. So it's up to you. I mean, which group you want to be. You want to appear as soon as possible and finish this tough exam quickly, and a lot of headaches will be gone. Or you can get into that group that once you finish one batch and then again rejoin the second one. Yeah, because we keep it very low, just $50 for rejoining the second batch. So many doctors join, but that's not the point. The point is you should finish your exam as soon as possible. Some doctors have very long gap. We really respect and appreciate that. We like to help those doctors, but those are fresh graduate. I mean, those have time. We appreciate you guys should finish these things in 5 months and then revise for 1 2 months and sit in the exam. Okay, with that note, we are going to start our session and all good wishes. Recently, there is, the PLAB results came. It was also tremendous result. Last our November and the February result was very good. November there was over 50 passed. I think 54 doctor passed out of 56. It was very good result. And also beginning of the new year results are so far coming good actually. So let's see. I mean, hope for the best for all of you as well. That the recall question and everything will be coming more in the exam. But recall is just a number, guys. Recall is like a gambling you're playing. I mean, if you are just expecting exactly same is coming, it varies actually how many numbers of recall you are doing. Previously, we used to say 1 year is more than enough, but sometimes we feel nowadays those are doing 2 years. I mean, they might have more good grip. I mean, it's very obvious if you do more practice of the recall question bank, you have much more better grip than anyone actually. So I won't take much time on this other things, but every day beginning of the class, I give 5 10 minutes advices on certain things. I mean, I hope so those were beneficial. I hope so you remember last day we give some advice on clinical gaps, right? Today is moreover about some study related thing. Suggestions are coming up. So let's not take much time and go and start the session. Do let me know if you can, see my screen very clearly. All right. I also like the presentation actually, and yes. Okay, so that's some interesting things. That's okay. Okay, yeah, no need to take it forward. Let me go and start. All right, so we'll be starting. This is our slide for today, and I hope so all of you will be following. And do let me know, I mean, if you like the presentation and the animation, those sometimes I make. I hope so. That's interesting, right? I mean, we used to see a lot of PowerPoints from different teachers of the world. I'm sure you have seen a lot in your medical colleges. So always, try to be a little bit more innovative. That looks a little different. You can see the same PowerPoint things are looking a little bit more killer type, probably, right? I mean, some animations going on, some the arrow we can see. I mean, so this is just the thing. Actually, you can do it always. Today's plans. Okay, what's plans are there today? Today is actually we are going to cover some of the basic rheumatology, clinical correlation, John Murtagh based study. Of course, we are going to do that John Murtagh based study, and they will be highlighting some of the major diseases. And at the same time, after class, there will be our class test of the previous topic actually. All right. So, and apart from that one, if we see what's coming now, see, we have two groups of doctors. Those of you are kind of like this girl, I mean, or maybe, man or, woman, whatever. And, sitting with a tab and maybe doing some other things. Please come back to laptop. All right. So just like a little, animation I try to do, maybe some of you can correlate actually, because after some time, your situation will be kind of like that. Either you're hearing music, either you are hearing doing this or that, but there is a group of doctors. Many times, those I suspect, I open up their video, so and we figure out that this is scenario. Some are also we found sleeping in the bed. Okay, so I mean, I hope so. Class is not that boring always that you need to sleep. Yes, at the end it might be a little tiring. I can understand, but of course not in first 1 hour of the class, right? So still you have time. Please leave this tab. Please leave this mobile because these are not the device for taking class. Your device is this one, your laptop for taking class. Okay. So quote of the day for today. It's never, I mean, impossible, unless it's done. It's a famous word by Nelson Mandela. Yes, so that's the thing actually. So this is, I mean, some of the things. Uh, Someday we'll really believe that your MC is done actually, and you are securing a job. Okay, that's very much possible actually. Another day I gave an example of a doctor. She just passed, last year at the end, and she secured a job in Australia. So that's the point actually you need to know. Books we're going to cover John Murtagh, I mean, and of course something from the Davidson. Those of you who are living in Bangladesh and if you have bestseller, you can also use it. It's currently not available any overseas delivery, or we don't use soft copy because the author don't allow the soft copy, because author and the distributor, there's a different things are there actually. All right, so that's the thing. So overseas things are not available. Those are in Bangladesh. You can collect it by calling Mr. Khalid actually, but that's okay. I mean, otherwise classes will be enough. Don't worry. I mean, just a book you can keep in collection, MC bestseller. But apart from that, John Murtagh, Davidson, it's also more than enough actually for. So all right, so we will be starting. So I hope so we are done with some today's plan, and I hope so you enjoyed some of the demonstration which I gave. So do let me know in the comment section. I mean, how's the presentation and the things usually looks like actually. And I will be going into initially John Murtagh, and we'll be getting into also Davidson today. So I'm going to share my screen again. I mean, and do let me know if you like the initial some of the demonstration. All right. So initially, we are going to open up this thing. I mean, which book is this? Which book is this? First of all, it's a very basic question. I'm sure if you were thinking this is actually Davidson's medicine. I'm sure many of you can correlate. Davidson has a nice thing I like about it. They gave the index in the beginning of every chapter. All right. So this is something given in the beginning of every chapter, actually. I mean, the Davidson's medicine. I mean, other books give it at the end, but Davidson is given in the beginning. So if you have weakness in any particular subject, you can always check that subject. Say example, you might have some inquiries, or you might have some confusion on Paget's disease. Other, all the confusion might be cleared from the John Murtagh, but maybe Paget's disease is not clear. or Paget disease is like a nice to know topic, so I might go superficial, but you are someone who wants to know a little bit more details. So in that case, what you can do, you can open up the Davidson, and from the first page, you can find out so easily, okay, Paget's disease in which page of Davidson? Okay, here's the page. Also, there's like another vice versa. From a recall topic might be coming out, maybe new. Sometimes not every theory topic might match with the recall. So sometimes one, two new topic might come out into the recall. So that topic, again, you can give a cross check with Davidson's medicine. Now, the next question often will be, doctor, do you have to read the Davidson? No, you don't have to read the Davidson in that way, except for some of the investigation we will go through actually, because rheumatology is a lot based on your investigation. Same goes with renal some cases, but those information of the class were enough from the John Murtagh. But rheumatology, we need a little bit more information from Davidson. So with your permission, we are going to start this one. So chapter is rheumatology. It's like 1057 is the page number. Basically, whoever has Davidson, you don't have to open it now actually. So just gather the information, write down the page number. So rheumatology, page 1 actually, or whatever, 1057. Now let's come to the picture side. Let's little focus here actually. Okay, I'll turn off myself. This might be distracting. Okay. Now here we can see for any rheumatological cases, we have appearance, gait, deformity, swelling, rash, a lot of points, right? We'll be going one by one and we will try to correlate with a lot of diseases actually. Now I'll be starting in that way. Tell me at least two conditions where you have joint deformity. A quick question to my dear doctors. I mean, this you have to really quick in this word. Which, I mean, at least two conditions where you have deformity in so two major diseases. You have to name major. And if you add minor, there might be more, but major. Okay, in major, first name rheumatoid arthritis, second name if you say osteo, that's also kind of fine actually. Pages if you say also is fine. So I would say well done, my dear doctor. So you know this already. Okay. Some of the cases gait can be affected. Like see now Paget's disease. Do you think in any way gait can be affected? What do you think about like the gait? I mean, you're walking and thing can be totally affected. Now, if you think about gait totally affected, like two of those conditions might be one can be the Paget's because there is directly bone involvement. Can I also add if you have acute gout in your great toe, your gait again can be little affected. Is it okay also? I mean, gout cases, the first metatarsal when affected, they cannot walk so smoothly. So you can correlate. So we are all talking about correlation right now. Swelling, it has a lot of condition. Whichever inflammatory, I repeat, whichever inflammatory, you have swelling. So say rheumatoid arthritis, you say gout, you say many other condition, reactive, all have swelling. All right. So that's one of the point. Now, redness. I mean, of course, whenever there's swelling, there will be a redness commonly actually. And lastly, rash. Name one rheumatological condition which has arthritis problem and which has skin problem and associated with rash. You have only 10 seconds to answer this. All right, so looking for a quick one. Yes, my dear doctors, if you say SLE, I mean, that's more accepted first. Okay, because we are looking for the major disease first. Then if you add psoriasis, you are also fine in that case. All right, someone said HPV, HSP, yeah, that's okay. I mean, leg to buttock rash and in kids. Or maybe we can skip the kids for a while. That's okay, actually. So SLE and the psoriatic, you can for now remember. Another condition we learned in the GIT, if you can remember, that was celiac disease. I'm not sure how many of you know when celiac will be associated with skin problem. They have same feature of malabsorption. I repeat, celiac has malabsorption, and that skin condition I'm going to tell, they also have malabsorption feature, but only extra feature is a skin problem. I'm talking about a condition, dermatitis herpetiformis. It's also multi-system disease, arthritis, malabsorption, vitamin deficiency, everything is there. Okay, but associated with rash. So see, this is the thing we are looking forward, and this is the thing we are talking about correlation. Are we clear, guys? Observation, what does it mean? Observation means this clinical observation. Okay, we'll start that one. I will go one by one. Heberden and Boucher nodule in osteoarthritis. Okay, everyone knows that. But which one is for which case? Now, Heberden I remembered as HDTV nowadays. Not really nowadays. Nowadays, a lot of types of televisions are coming. HD came, I think, like 10 years back. Okay, so HD. H means the Heberden's, D for distal metatarsal joint. Distal metatarsal joint, that's to remember. And Boucher's BP, I remember in that way. Okay, so Boucher for the proximal joint. Okay, proximal one Boucher, Heberden's for the distal, both related to osteoarthritis. Both related to osteoarthritis. Next coming, we can see what? What do you see, my dear doctors? I can see something, you know, the what should I say, Z-shaped deformity. If you agree with me a little bit, there is some kind of Z-shaped deformity I can notice here. What do you feel? All right. So if you see this one, this is the Z we're talking about. This is the Z-shaped deformity, and this is related to rheumatoid arthritis. Rheumatoid arthritis itself has, there is 7 different criteria. You can follow them. There's 7 different criteria for that to follow. Okay, next is coming, you know, nail related problem or skin related problem, again goes with psoriatic. So arthritic problem, rheumatological problem, nail related problem, if together they told is we are talking about psoriatic arthritis. Sometimes they will tell you skin related problem as well. Okay, we always check the hand. It's very important in case of locomotor system, right? This system demands locomotor system examination. Agreed, my dear doctors? This system we're talking about required locomotor system examination. How many of you agreed? I guess all, I think all of you. So we do check, I mean, this hand swelling, deformity, nail, even Raynaud's. Today, Raynaud's we will be discussing, and Raynaud's has arthritic problem at the same time some color changing problems, right? Like nail, I mean, this color changing problem with Raynaud's, we'll be talking about that one. So, but it's under rheumatological disease, and you can see this thing, nodules. These nodules are related to rheumatoid nodules. I repeat, these nodules are related to rheumatoid nodules, also Heberden and Boucher's, those type of nodules for the osteoarthritis nodules actually. Okay, so still we are correlating. Already I told one thing, if I tell about a major system disease, multi-system disease associated with butterfly rash, associated with butterfly rash. Everyone knows, I'm sure, I mean, I don't have to tell much. And we are talking about SLE. SLE has 11 criteria. Please take note, you can see it later. SLE has 11 criteria. You can search in Google later. What are the 11 criteria for SLE? What is the mnemonic for SLE? You can later find it out. Okay, easy one actually. And of course, you know, some major deformity in the body or trunk, like, you know, kyphosis, scoliosis. Name one condition which has trunk deformity. Name one major disease which has trunk deformity, like kyphosis, scoliosis, and something like that. You have only 10 seconds to think. And that condition is ankylosing spondylitis. If you say there is 6A, if you go to my YouTube channel and if you type ankylosing spondylitis and type my name, you know, so it will, there will be popped up of a ankylosing spondylitis video, and in that video I will be talking about there is like 6A. Okay, what are those 6? You have to find it from my YouTube channel. I'm not going to tell it today. Sometimes I want you guys to, you know, go to the YouTube and find it out actually. So no worries, we'll be discussing those points too. Still we're in the basic. These are the basics of rheumatology. All right, next coming is, you know, leg deformity. Already we talk about, like, you know, if we talk about the Pages, that's a classic example of deformity or leg deformity. But technically or indirectly we can say gout, because if you have gout you cannot walk properly. So that's like a somewhere, you know, your gait is affected again. And last but not the least, gout. From now on, always remember gout and pseudo gout together. Those of you who are freshers, not have gone through FCPS or any MRCP type of exam, you probably have only learned about acute gout in past. Actually, now here you have to learn also about pseudogout simultaneously. Whenever the gout name comes in AMC or PLAB type of exam, please do give a second thought about the pseudogout. So we'll be definitely discussing gout versus pseudogout. This is the very important one of the question. The question scenario always gives us either gout or pseudogout. You have to rule it out, or you have to give a treatment accordingly. So we'll be finding soon on that one. Next page is mostly about probably you can say locomotor system examination, mostly required for AMC clinical or lab clinical, whatever. Next, the most important thing before bringing something out, I just like to add here. Have you seen a doctor prescribing? Have you seen any doctor prescribing? Often rheumatological doctor prescribing something what they often prescribe CBC with C reactive protein. Have you noticed something like that? Some of you are very experienced. You guys already know that. But CBC with C reactive protein, I mean, those are new batches students, please they answer. Other batches, please keep quiet. I mean, if anyone is from, you can answer later. Why this is done? Can anyone tell me why this is given? I mean, what we like to check here actually? We like to check here something inflammatory. Will you agree with me guys on that one? Is this thing is indicating something inflammatory or infectious? Infectious is a different time. Better word is inflammation is there or not. Now, can you tell some rheumatological disease with inflammation? So some inflammatory rheumatological disease. Please add some names. If you want to start with rheumatoid arthritis, gouty arthritis, you are correct. Anything else from my dear doctors? More name, please. Okay, septic, well done. Anything. Now, this is the thing coming out. What do you think about osteoarthritis, my dear doctors? What do you think about osteoarthritis? Okay. Now, everyone say osteoarthritis, is it inflammatory or non-inflammatory? I repeat the thing. No, not degenerative. It has to be either inflammatory or non-inflammatory. You don't have the choice to say degenerative here. So here, if we see something, next page we are going, we have a nice table, and this table is very important. So inflammatory, non-inflammatory table must learn from Davidson's medicine. Now, if you see here some inflammatory conditions, and it includes these seronegatives also, means reactive is there, gout, these things all you say, but do you see any rheumatoid arthritis? No. Sorry, any osteoarthritis? No osteoarthritis here. No osteoarthritis here. Then where is osteoarthritis? Osteoarthritis is put into non-inflammatory, not very surprising, even though it has itis. I repeat, even though it has itis, but it is non-inflammatory. So this is a bigger mistake many doctors do. So that is one of the reason. This is one of the reason. I mean, this CBC with C reactive protein given, because they look forward to major diseases, and major diseases means if someone with a 50 year is coming, either it should be rheumatoid arthritis or septic arthritis, or it should be osteoarthritis, right? Normally things comes in that way. So when you know CBC and C reactive protein, these things are not elevated in that way, you quickly give a thought about osteoarthritis. Is it clear? I mean, bring this to your clinical practice. Very cheap test, but you get to know something very good. So this is one of the very important point we do. All right, next is coming. A few pictures and things are given. Next page, some rank and the thing. We don't need it for MC, okay? This thing I used to require for my SCPS passing, which I passed earlier, but it's not required for the MC. So we're moving forward to our next page. Here's something given about the types of joints. I mean, just a basic, you can just see it actually. One thing I like to add here. Okay, have you seen in any case of osteoarthritis patient? Now, NSAID is the first line, one of the first line of management in osteoarthritis. Agreed? What do you think? Any painkiller is one of the prime treatment for osteoarthritis. Will you agree with me? Or you like to give some antibiotic and some other thing else? I mean, in most of the cases, I think better to say painkiller, because acetaminophen, the paracetamol also used a lot in Australia as a treatment, right? So it can be a painkiller, better to say, not like always NSAIDs are given, so it's not always like that. Now, thing is, any supportive drug, you have to be a little quick, guys, in answering. Any supportive drug, it's also given in osteoarthritis cases. Now, and in Australia, if you go, it's when UK, if you go, is over the counter. It's available in many shops. I remember while I was coming back from Australia, I brought one of those big jar for my mom because because they are like 55 now, and those are over 50, 55, and often they have certain level of osteoarthritis. So what drug? I'm talking about not fish oil. Come on, dear. I mean, fish oil is available here in Bangladesh, but calcium, yeah, calcium is nice, good quality calcium is available in Australia. That's okay. I appreciate that. But question is calcium is a main treatment for osteoarthritis? Do you think, agree, guys? Is calcium is a treatment really for osteoarthritis always? I mean, not really. I mean, it's mostly for osteoporotic change. If I just correct it, if there is some osteoporotic change, then I will think I need to give calcium plus vitamin D. All right. I mean, osteopenia, the thing you are trying to say, it is called not osteoporosis, osteopenia. If osteopenic changes, then we give calcium plus active vitamin D. Now, next one, what drug I was talking about? Talking about glycosaminoglycan. I hope so some of you are remembering now from histology or pathology, glycosaminoglycan or glycosaminoglycan or hyaluronic acid. Somewhere here you'll find it. Chondroitin sulfate, glycosaminoglycan. What is these things are? These are nothing but related to synovial fluid. These are nothing but related to synovial fluid. So when you give these things, will you agree with me that the synovial fluid is increased? If I give glycosaminoglycan, synovial fluid level will be increased. Synovial fluid level is important for avoiding joint friction. I hope everyone is agreed. Synovial, this fluid is necessary to prevent the friction, between the joints actually. So we don't want that thing to happen. So that's why we give it. But it is not extremely useful. It has a lack of some evidences, but still it's a very popular drug treatment. Okay, we're getting for the next one in terms of the investigation. Now, joint aspiration has been done for 3 or 4 different conditions. Like what? Like if I want to start with one name, what it should be. If I want to start with one name, like without any delay, you directly have to do this joint aspiration. That's the first line of management in that condition. My answer is not gout, wrong answer. It's a septic. No, gout, we don't do the joint aspiration at first. We can go for the checking of blood serum uric acid level, right? For septic, without any further delay, we can directly go for joint aspiration. All right, so that's the thing. But apart from that, rheumatoid arthritis, osteoarthritis, gouty arthritis, we can go for joint aspiration as an investigation actually. Okay, next coming is a very interesting thing which I really like to discuss with all of you. And would you mind? Okay, like no worries. I hope you don't mind. We can discuss this interesting picture. Some of you might like it. How many of the female here likes this color? I'm just taking some time, as I said, I often do a lot of research. Often say pink might be pink, purple, everyone likes. So that's what, just, but now just trends are changing a lot. Female does not also like pink color actually. So, I don't get biased. If it's true, then just write it actually. Just want to take opinion actually. When I get married, I brought something, pink color for my wife, and I was telling her that, oh, I think it's a girly color, and I don't like pink. Okay. So what do you like? So she said, okay, I like blue, and no, wow. I also do like blue actually. All right. So that's the thing. But anyways, some female might also like a male to wear pink color shirt, maybe with a tie or something like that. But that's okay. We're not getting into that discussion. We bring something because so that you remember something here. Okay, next coming, there's two different colors looking like. One is this typical pink type, one is like purple type. That's not the point. The point is what is inside there. This is something called needle. Okay, this is something called needle. And this is also some kind of needle or maybe crystals actually. So do we know one thing? Gout is a what type of disease? Is it autoimmune disease, crystal deposition disease? Which one do you think is correct? Gout is basically is a crystal deposition, disease. And these crystals, when deposited in a particular joint, it causes a lot pain. Often it is said worst pain ever, isn't it? Worst pain ever. Two condition has worst pain ever. Compare and contrast. Often I ask this term. Two pain, it is said worst pain ever actually, according to. So one is this gout, and one it is, if you can remember, subarachnoid hemorrhage. I mean, it is often said worst pain ever. I mean, there's a lot of other condition worst pain ever. MI definitely is one of them. And 10 by 10 pain. Ureteric pain is also 10 by 10 pain. Anyways, but these are the terms often used in the books. I mean, worst pain ever. Anyways, I don't know why. So gout, crystal deposition disease. So what something has been deposited. So both this gout and pseudogout, there are some deposition. But if we talk about gout, the typical gout, it has deposition of what? Monosodium. Okay, so this monosodium crystal deposition disease. I hope so. All of you agreed on that one. Now, the test, this is actually test result. And this test result is what type of test? This is a PLM test. Now, who can tell me what is PLM test? PLM test is nothing but polarized then light microscopic. Actually, this is a microscopic finding, right? Otherwise, you cannot see like in this way. So this is a polarized light microscopic finding, and it has certain type of findings. So this polarized light microscopy showing negative birefringence. You please, everyone has to remember this. Polarized light microscopy. Everyone agreed on that one? Okay. So in that one, negative birefringence. Negative birefringence for gout. Whereas positive birefringence for pseudogout. Everyone agreed? Positive birefringence for pseudogout. This is the number one thing will help you differentiating in the main exam. Often it is given a scenario, someone comes with a pain either in great toe, either in ankle, either in knee, but you are not always sure by the side that this is gout or pseudogout. Now this takes us to one of the point, clinical scenario to believe more or lab to believe more. Now this is very important for the exam purpose. Clinical scenario versus lab. We believe more on the lab. Okay. So same goes with the gout. There is a very common question and a complex one. They will give you a scenario of pseudogout, but the lab is telling you negative birefringence. Sorry, lab will telling you positive birefringence. What is your diagnosis then? I repeat the question again. Clinical scenario showing elderly female who has pain in the knee, all right, or something like that, all right. So that might be pseudo, and again, lab showing, say example, negative birefringence. Now tell me, lab showing negative birefringence, but scenario showing elderly woman and blah blah this thing. Same one handbook question is available, guys. You can check it. Answer was given gout. So what is the final call? The lab finding is the final call. Everyone clear? The lab finding should be the final call, guys. All right. That's why the labs are done, right? Just to be sure. All right. Great. Now, guys, would you mind if I just finish the gout versus pseudogout and finish the gout disease? Because we started something. It's not a very tough thing. I mean, it will give us some relief, right? It will give us some kind of relief. Okay. Okay, let's bring it on. Now this one, what is gout? Already it's been told that this is a crystal deposition disease, uric acid and all this thing. But in case of pseudogout, what is something we're talking actually is a calcium pyrophosphate that is being deposited. Now one thing to add, if I say, will you agree? Yes, it's a more related to male. I mean, 3:1. I mean, in case of male, pseudogout more related to female. Okay, that's, I mean, initially, I mean, when we see something. Gout is related to needle. Everyone agreed? I hope so, yes. Gout, needle actually. You don't have to reply now. You can just take note now. So uric, then needle shape, and we can see here is a needle. Here is a needle actually. This one is kind of like a rhomboid. Remember the old math days? I used to hate math, by the way. Uh, this is kind of like that rhomboid shape. Will you agree with me? Now, think logically, a rhomboid shaped thing can cause more pain, or a needle will cause more pain. I think everyone knows needle will cause more pain, definitely. So it's a needle gout. Now, next coming is PLM, polarized light microscopy, showing what? This is showing negative birefringence, and this one will show positive birefringence. Very big point. I mean, during the lab to find out in case of gout versus pseudo gout. Very important for exam. Next thing is coming. Just to see the site and get an idea, is it gout or pseudo gout? Most of us know first metatarsal joint is the main point for gout. Main point for gout. You can also add the ankle here. That's not mentioned here. Please add the word ankle. So first metatarsal and ankle goes more with the gout. But doesn't mean it cannot happen in pseudogout. It can also do happen in pseudogout. And knee joint and female together, say 55-year female knee joint, when it is said, we think more about pseudogout. But we still wait for the lab to see. Finally, lab will come and lab will show that it is positive. Then we'll be actually sure that this is a case of pseudogout. Now I'm going to tell you another most important point here. Pseudogout, we are expecting a spatial history. I mean, I like to ask the new doctors first initially, then I'll go with the previous batch doctors actually. That what spatial history you want to see for a pseudogout patients. The time starts now. I mean, some people can wait before answering. Okay, some said OCP. All right. Anything else? Okay, now previous batch, they can also keep going with the answer. The answer is actually there would be a pre-existing. I know, actually none of them are correct. Pre-existing joint problem like rheumatoid arthritis or osteoarthritis. Please take note, my dear doctor. As I said, gout and pseudogout, I mean, we mostly learn about gout in the MBBS. We don't learn much about pseudogout. Now think logically. Your normal joint has more chances of getting damaged, or already damaged joint has more chances being damaged. What do you think? Already damaged joint has more chances of getting damaged. Very logical point. That is one of the reason in case of pseudo gout, like previously rheumatoid arthritis or osteoarthritis patient has more chances of developing pseudo gout. Clear, guys? Very nice, important history I'm giving here actually. Yes, sometimes we have seen thyroid in that one, but I haven't seen that one coming in our exam. From, as I said, those point I told earlier today, clinical correlation with the NCM, I am looking more forward here. So previously, pre-existing joint problem, pseudo gout can happen. Now, compare and contrast. Previously damaged joint, another situation can happen. Previously damaged joint, another situation can happen here. Not only pseudogout, there's another disease which is more prevalent in case of previously damaged joint. One particular disease I'm looking forward, the answer for that one is a septic arthritis. No, septic. Septic arthritis, like think logically, septic arthritis, some those of organism and thing suddenly came up. How? Because of there is already a damaged joint, and in damaged joint blood flow and many things are hampered. So the more chances of developing septic arthritis. Everyone clear? Some lot of interesting new points probably I told. Some of you might be know already, but for the freshers, you need to remember these points for passing the NC. Right? Good job. All right. And some radiographies are given. Rat bite, I'm not sure. I never have seen rat bite in my life in that way. Maybe Tom and Jerry, it's in my mind, but that's okay. Some rat bite probably it's given anyhow. Chondrocalcinosis, maybe that's evident. Chondrocalcinosis. I mean, this calcium thing deposition. That's more evident in case of, but rat bite, it looks tough to me. Anyways. First line of management, no doubt. Indomethacin is first line for gout, no doubt. Some people made confusion in case of pseudogout. It's also painkiller, my dear doctors. So painkiller or that NSAID is first line for gout, first line for pseudogout. So the pseudogout one, often people make some mistake answering. It's also answer is NSAID. So are we clear, guys? Are we clear with the concept? All right. I hope so, yes. Great. Well done, guys. I mean, I hope so the things are clear. I mean, we can little bit check from these things from what is our John Baba has to say, right? We should not ignore John Baba. He has a lot of things to say. So page number 378. Page number 378, John Murtagh. I'm giving you 10 seconds. You guys can probably like to open up your book. All right. So guys, 10 seconds I'm giving to open up this thing. Yeah, page number you can see 378 or 379. Now, as you can see, guys, in case of gout, few terms I have written. Before that, you can also check it from Master at the Board 167 page. And handbook, there is two gout question in handbook, 2.141 and 3.064. You can also write it near to your John Murtagh. My job is to make your John Murtagh also ready for your final showdown, actually. Okay, I could have come up with some, killer presentation and things like that. I have shown you in the beginning, right? Even it doesn't mean that I cannot make good presentation, sometimes. So that's why I show you in the beginning, actually, that, if I make presentation, it will be also very killer presentation. Actually, it looks good, but end of the day, if I don't foresee you reading John Murtagh, you will not study it. You will be only dependent to slide, and somehow, somewhere you will be stuck because many of us don't have the habit of reading main books, actually. So I just try to make that main book user friendly to you because John Murtagh is a complicated book, to be honest. How many of you agreed John Murtagh is a complicated book? I know when I started, I also agreed the same. It's somewhere is a complicated book, user friendly book like Master at the Board. That is really user friendly book, right? So anyways, I mean, let's go and start this. I mean, crystal deposition disease, agreed, extremely painful, worst pain ever. First metatarsal involved, another key point. Aggravated with red meat or alcohol. This is something I found in the exam question. This is something is aggravated with red meat or alcohol. I mean, binge drinking. Have you heard this term before? Binge drinking. I mean, lot of drinking someone is doing, and gout will be aggravated. There was also a scenario like that in past. Okay. So these are some of the key points. Gout versus pseudogout. Do I have to repeat it again? Gout versus pseudogout. I hope so. We are familiar now, right? Gout versus pseudogout, which I was supposed to say here. Okay. Next thing coming up, it's a disease related to male or man. I mean, so more in men, more pain in the early morning because overnight deposition, overnight more deposition, in the morning more pain. As similar like, what should I say, rheumatoid arthritis, in the morning more pain. Gout showing, I mean, some findings, metatarsal joint, red, swollen, everything is there. Now, some aggravating factor, we already told, I mean, binge drinking. Can you say one thing, I mean, in which after festival that gout thing has increased? Just a general knowledge question. After some festival, some say holy, but I don't think so you guys eat that much of meat, I guess. I guess, especially for Muslim, that Kurbani Eid, we called actually. I think Christmas is okay. People maybe love steak or things like that. But yes, I think after festival, yes, in that term that, after Holi and Christmas, the drinking thing, the drinking, probably the alcohol thing. And for Muslims, I think for us, I think that red meat actually, because everyone's house, there's so many, meat out there actually, either beef or lamb. And your mom is also telling you, okay, eat more. I mean, I need to clear my fridge. You guys can eat more actually. So we eat a lot actually that time. But anyways, but after that, those have the history of gout. I mean, those aggravates. So I just like to add something here. When I was like third or fourth year, of course, I'm not doctor that time, but my mom had pain actually. She was complaining of pain in her ankle for consecutive time. It was not going with painkiller. So because we learned that time history taking and those things. So I was checking in very details. Why history taking is important? Because she went to a very good doctor and still the problem was not solving. Because the sometimes professor don't have that much time to listen to the history. So I was checking the drugs. I was just third, fourth year actually. I mean, I learned the pharma that time. So I figured out one thing that, she was taking one antihypertensive drug, and that one was actually indapamide. Now, what is indapamide, guys? Any idea? She was taking indapamide. So indapamide is nothing but actually diuretics. It's one of those diuretics. So because she was using the diuretics, and diuretic has the property of hyperuricemia. Remember, the in past we all learned the side effects of diuretics, hyperuricemia. There is a lot of hypo, then two hyper, right? I mean, so that hyperuricemia is one of them actually. So I just told her maybe this is the reason actually. So I told her, okay, you can go and ask the doctor. I'm not very sure. And she went and she said, oh, yes, I mean, that's the reason, probably. Sorry, I missed it out. I don't know, but who made the diagnosis? My son made the diagnosis. Oh, okay, he will be a good doctor. Don't worry. So, anyways, it's not about good doctor. I think it's a very basic thing, first of all. You need to figure it out, find it out. So always there is a reason. We just need to find it out, actually. That's the thing. So first metatarsal is 75% cases, but can be in many other places. Tophi it can be. Okay. One of the exam question told that there is tophi. I should take this condition as acute gout, or I should take this condition as a chronic gout. What do you think? A person presented with tophi didn't mention that the person has severe pain. Didn't mention about that one. So pain comes on and off. Something she told, and tophi. So she came for adjusting the drug or something, because why? I mean, for name a drug that can be used for chronic gout. Indomethacin, we know it's a drug for acute gout, but there is a drug for chronic gout too. And the drug name is, what is that? No, colchicine is for acute, dear. Colchicine is for acute. Allopurinol, yes. Febuxosted or allopurinol. Febuxosted option I didn't see much in MC. Allopurinol, we do see that one. Allopurinol. Now tell me one thing. If someone has renal impairment, I mean, I'm sure you will be agreed that gout can also hamper our kidney. If you don't take measurement in gout, some people don't want to take drugs, telling, okay, don't worry, I don't bother. So you have to tell them, see, if you don't take measurement, this gout can harm your kidney. All right, so that's the thing. So that is one of the reason. I mean, we also need to give drugs like febuxosted or allopurinol. They work in the same way. I repeat, they work in the same way. All right. Now, when you give that one, if already renal failure developed, renal impairment developed, creatinine is high, should we give allopurinol? I hope so you got the question. If renal impairment is there, should we introduce the allopurinol that time? Answer is no way. We don't. Now let's bring me to one of those questions. I mean, there's a tricky one regarding pharma, and this question often comes and asked in AMC. They will put you just in trouble from the regular practice. Question is, the patient is having renal failure, and renal failure, a lot of things. Say creatinine is 1.8. All right, and plus hyperuricemia. Hyperuricemia. All right. Now We cannot give NSAID and the things like that. Depends on what type of patient is that. Okay, acute pain controlled. Controlled with what? Acute pain controlled with what? Okay, acute pain controlled with indomethacin, right? Okay, now that's one of the wrong answer would be NSAID because the person has renal impairment. So you cannot use NSAIDs. You should use steroid or low dose Colchi. I hope so clear. Please do remember, if you use colchicine, it can cause some diarrhea. Possible? Yes, definitely. It's an exam question, by the way. Now, this is how the acute pain is controlled. Now, one of the question is coming. Do we give allopurinol on acute gout? Another question is coming here. Now, if we don't give allopurinol in acute gout, why it's the reason? Answer for that one, when you give allopurinol, all the crystals are broken down. Now more pieces of crystals are produced and there will be more pain. So this is one of the things, when we give allopurinol, the pain actually increased. When you already have pain, I mean worse, and then you make it even more worse. Okay, so it's like bad, you make it worse, something like that. Okay, so that is one of the reasons we don't give allopurinol when there is acute gout. It's contraindicated. Then when we give it, we give after certain time. All right. Now we have to also check comorbidity. What do you mean by comorbid factor? Like this one here, renal failure. So can you introduce allopurinol in that case? Can you introduce allopurinol in that case? Answer is no. We cannot use allopurinol when. So then what? Then we have to correct the creatinine and the things, and then we can move forward. Up to this, everyone clear? Up to this, everyone clear, guys? I mean, the last part. Allopurinol, we cannot give in acute gout case. Allopurinol we also cannot give if there is renal failure already developed. Now, this brings me to one of the second question. Let's take one of the second question. The second one is coming. A patient on allopurinol for last 6 years. Now the patient develops renal failure, showing 1.5. Patient already on allopurinol for last 6 years. Now this patient develops renal failure. What to do? I mean, first option, should we stop allopurinol? Stop allopurinol, continue allopurinol. All right, best answer here would be continue allopurinol. What will be the best answer? Best answer to adjust the dose. Adjust the allopurinol dose. Okay, so we can continue. If it's about just true and false, we can continue allopurinol, but we just have to adjust the dose because every renal failure. Now, see, guys, if you are giving antibiotic to renal failure patient, do you think the same dose you have to give it, or you just need to adjust the dose? Answer: you have to adjust the dose, isn't it? Every renal failure patient, you need to adjust the dose. Actually, most cases, yes. So same thing here. You just need to adjust the dose because it depends on the half-life when it will be out from the body. Is it clear, my dear doctors? Everyone clear with the concept? I hope so. I just try to make it clear to all of you. Let me show you a gout picture. Okay, doesn't seem good, right? Actually, I have a cousin and he's has gout, and this one you can take a little. I mean, little pharma related things are also given, but I found this slide very useful always. Okay, I mean, in general, you can see some related to acute gout, colchicine, NSAID like naproxen or indomethacin. Colchicine again can cause diarrhea, by the way, GI side effect. And some of the drugs can be used for chronic cases like probenecid, allopurinol, febuxostat. By the way, allopurinol and febuxostat has the similar mechanism of action. Inhibit xanthine, inhibit xanthine. By the way, mechanism of action, we don't need it for AMC. I'm just telling it for nice to know as a purpose. Okay. Alternative of this allopurinol, I mean, if there is major issues, you can go with the probenecid too. I hope so. This clears your doubt, guys. I hope so your doubts are clear for acute and the chronic. Few new things we learned, right? Some clinical correlation. See, questions are not like the same before. I mean, previously we learned what are the side effects of allopurinol, what are the side effects of colchicine. It's not like that. Now we just need to last main things. Repeat the last point. Okay, last point. Okay, last point is actually what is the alternative of allopurinol? Alternative of allopurinol is probenecid. I mean, it can be an alternative because febuxostat and allopurinol is similar way it works. All right, so just can take it as alternative. Okay, so that's the thing. I hope so it helps actually. It's just an alternative. I mean, it's a drug also for chronic gout. So if there is major issues with allopurinol, you can switch to probenecid in that case. Okay, anything else? Let me see. Maybe this slide can be useful. I take it from the master debug, guys. Can be useful for some of you. NSAIDs are superior to colchicine. Some of you might ask, doctor, colchicine and NSAIDs both are there in the option. Both are for acute gout. Which one to choose? A simple, innocent question. Then your answer would be, I mean, do you like to go with indomethacin or colchicine? Of course, my answer would be indomethacin in that case. It's a very common question. If associated with renal failure, you see this one? If associated with renal failure, renal insufficiency, can I use NSAID? No. Then what should I use? Corticosteroid. Clear, guys? Okay. Oh, one more thing. My third and last point. No option for steroid given in the question. No option of steroid given in the option in a renal failure case. NSAIDs given and colchicine given. Then which one to choose? Your answer would be, we have to choose in that case colchicine, because low dose colchicine, now like the low dose is not always be mentioned. They might mention only colchicine, but as a general knowledge, you need to keep it in mind. Colchicine as a low dose means as an adjustment dose. You can use also in renal failure, but NSAID, no matter, I mean, low dose or high dose, you should not use it. Is it clear, my dear doctors? Lot of confusions, I hope, are being cleared about gout today actually. All right, so I think that's the presentation from the gout. We can go back to our original. We came up to far way. Are we clear with gouts? I guess yes. Few new things you learned, I'm not sure. I mean, I hope so you do. All right. I hope so few new things, at least one new point if you learned, I'll be feeling very lucky then. Thank you. So joint, we were in the investigation, we discussed about joint aspiration, then we learned about polarized light microscopy testing. I mean, what do you mean by positive? What do you mean negative? Then we jumped into the gout, then came back to this slide again, plain radiography. I think most of the rheumatological condition we're starting with an X-ray, back pain, X-ray. Many cases, I mean, in rheumatological, we start with X-ray. And what are those conditions like osteoporotic cases, osteopenic cases, bony related any cases, fracture related any cases, wherever you feel joint space can be narrow, you need to go for X-ray eventually. Everyone clear on that one? I think no doubt. Even osteoarthritis. Imagine your grandparents and things, they have pain in the joint. What do you suggest for them? A simple X-ray. Okay, to go and do a knee joint X-ray, right? So that's how it's done actually. So osteoarthritis. Now, one more thing in osteoarthritis, why we do X-ray? Two reasons. One, there can be joint space narrowing, or if there is any other diseases, okay, sometimes we also do tests to rule out other condition. All right, so this is how it's done. We're moving to the next page. A few isotope bone scanning things are given. I mean, not much recommended here. MRI, some MRI points are given. I mean, it's also nice to know one MRI points. Some synovitis cases. I hope so you'll agree. Some ligament related issues or synovitis type of thing you can see in ultrasound actually. But I haven't seen any question coming on that one. Okay, so you'll be relaxed a little bit. Then comes CT, same goes with MRI. I mean, nothing significant. The one that is actually significant is coming up now. And that one is probably this condition that is called osteoporosis. Osteoporosis, actually. Osteoporosis is our rheumatological topic. Osteoporosis is our endocrine topic. Osteoporosis is also our, I mean, gynecological topic. Okay, so that means it's an important one actually. Now, I would just like to draw a few things if that's okay with all of you. Okay, before drawing, I can show you an X-ray and we can see an X-ray here already given. What is this X-ray presented to you? Can anyone tell me the finding? I can see something black, more black. This is called what? Any idea? Quick answer, please. We don't have always that much time. So this, you know, certain thing, I mean, it's mostly done is some kind of DEXA scan. I mean, this is basically a DEXA scan given. But if we do an X-ray and also X-ray showing some kind of black color things, it's actually, those are changes. What changes? These are some kind of osteopenic changes. If I go more specific, these are osteophytes. Exactly. Some kind of osteophytic changes, osteopenic changes, this more black color. I mean, normally the calcium is white color. We don't see the black color. But if we see more black color inside the bone, that means the more calcium has been out, right? So this is the osteopenic changes. Actually, the calcium is out from the bone and went to the blood. Right, so that's the thing. So we have a test which is called DEXA scan, bone scan. Right, guys? DEXA scan or bony scan, we call it. It has some ranges which I'm going to clear now to you if you are ready now. So our topic is osteoporosis. Now, in terms of osteoporosis, that's a big term, osteoporosis. Before that, normal. Before that, osteopenia, osteoporosis. Please write in the same way I'm writing. Minus, I mean 1, yeah, 1 to -1. I mean, very weird ranges given. I mean, +1 to -1, that's, I mean, then it comes like somewhere like -1 to -2.5 osteopenic range, and finally comes -2.5. Example, just to make it easy, if it is given -2.8, DEXA showing -2.8 with back pain, your diagnosis please, osteopenia, osteoporosis, or is it normal? DEXA showing -2.8. According to this chart, this is called porosis, which is beyond -2.5. Now let me bring a chart for you, make it even more easy and complete for you. Okay, before going into the main chart, just keep it in mind, osteoporosis risk factors. As a lot of sedentary lifestyle. Are we doctors are in risk of osteoporosis? What do you think? Especially female doctors. Are we in risk of osteoporosis? Yes, of course. Sedentary lifestyle, right? Then oral contraceptive pill, many things. I mean, it's okay, come on, we are all doctors here. I mean, even those of female often use the contraceptive, try, switch over sometimes. It's called, always if you're using it, you are risking yourself for two things. One is this osteoporosis, and one is that estrogen related other issues like migraine, and also that stroke, and you are inviting those things actually. So It seems very easy always, but the time progresses, the complication raises. Also, because of the hormone, the mood swings are sometimes more common actually. Okay, so take a more better suggestion from gynecologist and thing about some of the other methods too. It's just a tip as a uh, doctor, maybe doctor suggestion to doctor actually. But anyways, thing is osteoporosis risk factor. These are the risk factors actually: sedentary lifestyle, estrogen, and maybe more. Uh, some of the points ignored. All right, I'm coming to those points. This is a DEXA scan, which I just now show you guys. This yellow color is related to what, guys? Yellow color. No, I'm not telling you the points. I just tell you yellow color. -1 to -2.5. This is the DEXA scan. My question is, what is the treatment? My question is, what is the treatment for this? The answer and the treatment for this is calcium plus vitamin D. If you say only calcium, it's not correct properly. Calcium plus active vitamin D. For treatment for the red zone, I repeat guys, treatment for this red zone, like -2.5 to -3 or even beyond, your treatment is, what is that? Bisphosphonate. If you have to tell one word, alendronate is not the always the treatment. I mean, the broad term you have to use, that is bisphosphonate. Alendronate is under those bisphosphonates actually. Okay. The red zone is a osteoporosis. So you need something better. You need something better. Yeah, this is the thing that happens in osteoporosis. I'll come to those points shortly. Yes. This is the picture I was looking for. I hope so you guys can take a snap or screenshot. Maybe I can make it a little bit bigger. Yes. I'm holding it for 10 seconds. You guys take a snap for relatives. Now, are we clear about the ranges? I'm sure you do. I mean, which is normal. Initially, I was talking about what is normal. What is osteopenia? What is osteoporosis? I mean that green zone, yellow zone. I mean, think as traffic light. I mean, before getting into the, becoming the red, there is a yellow. So the osteopenia is the alarm that, it's becoming yellow. So you should try with calcium plus vitamin D. But if osteoporosis is happening, you need to try with bisphosphonate, better term. Often it comes in exam as alendronate. Next, one popular question. Someone with osteoporosis and someone with peptic ulcer disease, and it is very active peptic ulcer disease. I'm sure some of you might be knowing alendronate is not GIT friendly. Agreed? Alendronate is not GIT friendly. It is true, alendronate is not GIT friendly. I mean, it causes, and especially the oral one has very large side effect. I'm telling you, oral one has very large side effect. That is the reason when you give oral one, you have to sit for 1 hour. IV has better complaint, but doesn't mean it totally 100% safe. Is it clear, guys? IV alendronate doesn't mean always 100% safe, like for that. I mean, if there is GIT problem, still if it's there. Now, what is the solution? If someone has active peptic ulcer, then there is an alternative option. It is written, as you can see, alendronate, or I wrote zolindronic acid. Zolindronic acid. So this zolindronic acid, especially IV, you need to use it. This is all under bisphosphonate. Clear, my dear doctors? New thing, right? A little new thing for some doctors actually. Don't get afraid with some of the doctors, because some from previous batch, they know the answers actually. All right. Next, if it is given, try to answer it. -1.8. What to do next? -1.8 by DEXA scan. What to do next? Your answer will be calcium plus vitamin D. I repeat, answer will be calcium plus vitamin D. If it is said -2.9, what to do next? -2.9, what to do next? Then your answer will be alendronate or bisphosphonate. Interesting. I mean, all I took from different recalls and from past papers. Next, minus 2.8 and history of breast cancer 10 years back. Now, there is a tail in this question. Now, new doctors to answer this one. What is your opinion on that one? Using alendronate. In some of the previous, they know it already. I want the new doctors to answer it actually. I don't appreciate answering, the new, I mean, only new doctors, please, actually. I mean, old doctors, please, you guys are mostly observer here, actually, to help out the new doctors. Okay, so sometime appreciate. Okay, so many of you answered this one as alendronate, actually. Actually, the correct answer for this one, I repeat, the correct answer for this one is tamoxifen, all right? Its answer is more correct answer is tamoxifen or raloxifene. I mean both. This one. These are called what? These are also bisphosphonates, but their main name is estrogen. I mean modulators mostly. SERM, yes. Right. So you can check it more later. What type of drug is tamoxifen? What type of drug is raloxifene? Little, you have to do little own research, right? Tamoxifen, raloxifene. Take note. You'll see it later. Tamoxifen or raloxifene. Now, in between these two, which one is more safer in breast cancer? There is another question. I mean, they always come up with twist in main exam. My theory lecture is not like always like the typical theory. It's based on the clinical correlation and the exam papers. As I'm telling right now, that they will ask you in between tamoxifen and raloxifene in a breast cancer case, which one do you think it is more safe? I repeat the question. I mean, the third one, if it is there, tamoxi or raloxi, which one to choose actually? Okay, we'll find it out soon. One trial has shown directly that compared to tamoxi and raloxi, raloxi is slightly less effective than tamoxi in preventing breast cancer. Now, which one think is better here using osteoporosis and breast cancer? There is an article given. You can take a snap and read it. I want you guys to read it. It's okay. I can wait for 15 seconds, but many of you later won't read it. I know that. So please read it for 15 seconds properly and give your answer. Everyone answer this one, please. There's a comparison done. I mean, that's the topic. Very clearly say raloxi is less effective. Now, you can ask me, doctor, it's not written in book. Yes, dear. This type of statements are not always given in books. So we have to take sometimes help from some reliable, website. I think this was taken from either RSCGP or Medscape. According to this one, I think tamoxifen is a better choice. Will you agree? According to this one, this tamoxi is a better choice. So if they confuse you in the main exam, giving both tamoxi and raloxi, which one is a better answer? Tamoxi is a better answer. Clear? So one more question. I'm solving a lot of questions. Even though I'm teaching theory, but I'm trying to solve a lot of questions. Next, another question they will ask about osteoporosis is this red one, red zone. Answer of a complex recall. Osteoporosis, they will give you, it's a known case of osteoporosis, or they will attach an X-ray or DEXA. And now your patient presented with fracture. Just to make it easy, please imagine, or maybe you have known a lot of relative or maybe someone's parents, they fall down into the bathroom, somehow slipped into the bathtub and they have fractured their femur. Have you heard this kind of stories? Or is this thing happen in your own family? Do let me know in that case. This thing has happened. Now the next question is coming. Do we also fall down, in bathroom, maybe accidentally? That's also answer. I mean, if we take our whole history of our life, we also have history of falling down in bathroom. But do we fracture our femur? No. Why they fractured their femur? Because it's very much weak. So the weak bone has more chances of fracture. Agreed, guys? The weaker bone has more chances of fracture when you fall down. And this fracture or trauma is called a low trauma fracture. Someone falling from bathroom and fractured their femur. Is that a high trauma or low trauma? It's a low trauma. High trauma means what? Road traffic accident. I mean, someone has car collision accident. That's a, like, high trauma. Someone fall down from stairs. That's a high trauma fracture. So low trauma fracture, what we should do next? I mean, they will confuse you in between two options. Should you, I mean, after initial resuscitation, of course, initially IV fluid, blood, surgery, these things will be done. So after resuscitation, you like to give DEXA, or you like to, just give me a second, or directly give alendronate. So two options will be given. Do the DEXA or bone scan first, and then give the alendronate, or directly give the alendronate. I hope so you get my question. Either you are introducing the drug directly, thinking that, okay, this is a known case of almost osteoporosis. So we just need to give the alendronate. It's a known case. Another option, you again do the test, redo the test, and then give it. Now, thing is, I mean, this is a lot of controversy, and the answer is according to the Red Book. Now, this type of chart are present in the Red Book. Red Book is a book, by the way. So DEXA at presentation. See, this is the references and evidences we need. DEXA at presentation. Clear, my dear doctors? Now, question, why? Some might be also thinking why. One doctor was telling, doctor, I mean, I was telling, you guys don't ask the questions much in the boxes. I mean, there is an inquiry zone. Those doctor, most of the thing when we think about the question, you answer it actually in the classes, but that's okay. But still try to ask questions. I'll be happy, when you ask the questions in the comment section actually. But anyways, I mean, why? I mean, the answer is the fracture may be happening in the right side. Do you think your left side can be also weak in the same way? The left side can be also is in risk? Just thinking logically, of course. Since the right one has broken, the left one is probably also in risk. And you, my dear friend, again need the DEXA scan to rule it out. DEXA scan and bone scan shows not only the femur, that the humerus parts and many other those parts are very weak. Okay, so you'll get a full idea, and if it's necessary, you really need to know like what other parts are in risk, and you take according measures, right? So that is the reason DEXA first is still, then alendronate. Whatever is supposed to happen has happened. Now we have to be careful by doing the DEXA. Okay, clear? I mean, so this one, it looks very small, just one page, but how many questions actually we solved? Actually, we solved, I can say 5 or 6 questions has been solved in just one slide like that. So osteoporosis in a nutshell. Osteoporosis in a nutshell. Few of the things you can remember, like sedentary worker, someone is using steroid for a long time. I mean, they might ask you something about the risk factor related thing. Anyways, can we move forward from this one? Can we move forward from this one? I think we are somewhere done with the osteoporosis. They might also make you a lot of suffer with HRT in future. I mean, when to use HRT, when not to use HRT. I mean, if you get some time, I mean, tomorrow try to also learn about little about HRT, even though it's a gynae topic, but it's also topic related to osteoporosis. Okay, so try to learn a little bit, take it as a home task. You will also see, I mean, what is the indication of HRT, what is the contraindication of HRT. HRT means hormone replacement therapy, which is usually given after the menopause alone. Okay, a lot of things. Then coming, still we're going with the investigation things, and CBC thing I told already, right? We do CBC and C reactive protein. I think I explained told already. Now, next coming one thing. Paget's disease, apart from the X-ray, gives one name of one of the blood tests. I repeat, Paget's disease, please give one of the blood test name specific apart from X-ray. X-ray shows, I mean, bone deformity, bone, I mean, in different shape, liver function. Someone said, no, I think specific. All doctors can also answer. So answer for this one is alkaline phosphatase. My dear doctors, if you see this one, isn't it this one is a very specific finding for Paget's? Answer is yes. And in terms of the Paget's, I will show you something. I mean, not too many things you need to know from Paget's. What happens in Paget? First question. What really happens in Paget? There is excess deposition of calcium type of thing. Will you agree on that one? There's like excess deposition. The bones will become like some kind of like chalk. You see, excess deposition of calcium, is it good for bone or bad for bone? Just general knowledge checking. Excess deposition is actually, I mean, will it be more stronger? I mean, some of you might be thinking, okay, excess deposition of calcium, okay, more strong bone. No, it's not. It's actually just imagine the class and there is like chalk, right? So chalks are more easily breakable because there's too many calcium deposition. So excess anything is not good. So Paget's disease of the bone, my dear doctors, more common, I mean, affects over 55. For exam, it's very important to remember. I mean, so elderly age group, Paget's is more common, right? Another main complaint is bone pain. They might present with fracture because they have fragile bone. Imagine the chalk and the Paget's disease. Associated accelerated rate of bone turnover. Accelerated bone turnover. I mean, are you expecting more blastic thing here or are you expecting more clastic activities here? Just I think general knowledge question. Here they have more blastic, I mean over blastic activity. Normally we want blastic activity, it's good, bone formation, but here is over blastic activity. So please take a note, not blastic, it's like a bone blastic activity. Okay, good word, right? Okay, next coming. We definitely need to rule out how by X-ray we will find lytic bone ration. Okay, bone deformity, yes. Blood will show very classically raised ALP, alkaline phosphatase. And of course, you can do bone scan, urine, and all these things. What is treatment of Paget's disease? Very interesting. Treatment is bisphosphonate. Very interesting. Among the bisphosphonate is pamidronate. Not alendronate here, pamidronate. Clear, guys? So I just try to make it as much as easy for you with some key terms. Alkaline phosphate being the very classical finding, and treatment is bisphosphonate and more blastic turnover. Just remember bone blastic activity. I mean bone blastic activity of osteoblast. Remember in that way. If you remember something with the unusual term, it's always easy to remember. Now, when there is bone blastic activity, of course, the bone has a lot effect. Bone is breakable. We got it. We understand that. But apart from that one, it's also deposited in the bones of the ear. I mean, inside our eardrums, there are some bones. Who remember the names? I might forget, but I remember somehow. Anyways, there are like 3 bones actually: Malleus, in a yes, Malleus, incus, and stapes. Right? Yes, I remember. I guess yes, 3 bones. Now, what will happen with those 3 bones? There will be over deposition, right? And over deposition is not good. Over deposition. So now, can they hear properly, or will they hear more? I mean, will it be affected? So hearing will be eventually affected because it's like a band music. There has to be proper drumming, proper acceleration, proper everything. It will not happen because the bones are in abnormal. What if you start playing drums with the elephant's tooth? I mean, some cases, if drum is big, that's a different thing. But as like a normal drum, if you bring elephant's tooth and you start hitting it, not a best idea, right? So same thing will happen here actually. So they will start hearing less. It also start depositing in the head. So head X-ray will show something, and also depositing in the brain area. So it might start compressing some of the additional matters. All right. So it might affect certain brain parts too. All right. So space will be narrowed eventually. So might develop hydrocephalus eventually. Anyway, some little additional term actually. All right, understandable, guys. I mean, it's a basically a nice to know topic. So since this came up, I just explained it. Is it clear, my dear doctors? Paget is clear to all. Just remember those key terms I say. All the rest. Next is coming CK. Now, if I say CK, some people's mind it will come up. What? Kelvin Klein, right? All right. So, how many of you like Kelvin Klein? I'm not sure. I mean, it's a universal. I think for both men, women. I think Kelvin Klein has a lot of things. Yeah. All right. I mean, I think everyone's universal choice CK. All right, but we don't want someone's CK to get traced. CK, the perfume or cloth is good, but not the. So CK is basically here. We mean to say creatinine kinase that comes from muscle. So a lot of muscle-related disorder are related to increased CK. Agreed? I'm sure you do, yes. So any myositis, muscle include MI, also CK will be raised. Then any trauma to the muscle, excessive exercise, also CK raised, interesting, yes. Okay. And any type of myositis or vasculitis, right? Just better to be known actually, better to be known. And one thing that is special, my special slide here, you need to remember this one. See, lot of myo given. Looks like a mayonnaise, but anyways. So myo, and drug-induced myositis, and again, I will explain it later to you. Please take a snap now, actually. But this is a classic slide to answer at least 3 to 4 questions. All right, I made it this slide, so keep it to yourself. Try not to share it outside. This kind of things takes a lot of time to make it. All right. So since drug-induced cases there is no real muscle involvement, that is the reason CK remains normal here. Polymyalgia rheumaticus, not really exact muscle-related problem, so still CK remains the normal. And in polymyositis, there's a very poly, a lot. Poly means lot, and myositis. So poly, lot of muscle. Remember. So definitely CK raise. That is how I remember. I will explain it later. I mean, when polymyositis and these things comes. Or do you guys want I should explain the polymyositis, polymyalgia rheumatica, drug-induced myositis, all here right now? Is that okay? I guess that will be more easy. Yeah. Yes. Here will be. I mean, correlation is more interesting. Okay. Let's go with the polymyositis. Remember one additional term. When I say polymyositis, you should also remember dermatomyositis. Polymyositis, dermatomyositis, same thing. Polymyositis, dermatomyositis, same thing. Okay, let's bring it out from our, let's call John Murtagh. Just give me a second. Yes, we got it. It's given in page number 316 page, my dear doctors. 316 page. I'm going to explain it, don't worry. There are just few conditions. Where is it? Oh, here it is. It's almost to 316, yeah, 316, 317. It is in 316 and 317. You see, both the names are written all together, poly and dharma. Okay. Difference, drug, and picture must. Okay, this is the picture I was talking about. Clear, guys? Everyone, I mean, at least a lab idea you guys got. Okay, we're coming to the point, but the difference chart of lab is very important to differentiate, because they have shared, I mean, all of these three has shared one of the common clinical scenario. And what is that? One of the very common clinical scenario, and that is proximal muscle myopathy. Do you know what is this? And can anyone give, I mean, again, last best doctors are, please wait for 30 seconds to answer. Proximal muscle myopathy example can you give? I give you example. Example, getting up from chair, you need your proximal muscle more involved. Getting up from chair. Getting up from chair. Example, you wash your clothes and you put into a hanger. Again, you have to raise your arms above the shoulder. Okay, so again the shoulder would be affected. Getting up from chair, your hip joints again need more power. And next is coming is actually is yes, and of course the one thing is very common in case of female. Okay, so that is probably combing. I think 100 times they do. I mean, no offense. I'm telling, considering my wife actually maybe. I'm not sure. But, we actually do one or two maximum. But, but it's okay. They have long hair, so it's different actually. I mean, no offense, guys. Please don't mind. Yes. But many do so many times. Actually, it's good actually to keep it healthy and clean, I guess, actually. So thing is, in case of female, I mean, so what do you think, if, because rheumatological diseases are much common in female, and if a female is coming with a complaint, what complaint they will tell you? Of course, they will not come and tell you, I have problem getting up from chair. They will come and tell you, I have problem in combing, isn't it? Again, with due respect. So problem in combing here actually. All right. So anyways, this is one of the very common problem for all of those actually: polymyositis, polymyalgia, rheumatica, and drug-induced myositis. All of them having, sharing the similar complaint. Okay, so getting up from chair. Now, if I take this thing to a children's disease, which we'll discuss in pediatrics, there is a one common scenario. A children also has problem in getting up. Have you seen this kind of scenario? A children holding his own leg or something, then they are getting up gradually. Yes, I'll teach that one in pediatrics, but just for now, know the name. This is called, Duchenne muscular dystrophy. Have you heard this name before? Yes, I'm sure you do. How many of you have seen patient? How many of you have seen patient in your life? I'm sure I have seen two actually. Very interesting actually, and they have to get up. Yes, and but by the way, guys, it's also available in YouTube. If you want to see the Gower sign, yes, someone said the sign is called Gower sign. So you can go to YouTube and just type Gower sign, you will find. Oh, one in family. Okay, all right, that's sad probably. Okay, so that's the different. I mean, we'll discuss, but they have the common. Then how to differentiate by lab, and what lab we like to do? ESR and CK. What lab we like to do? ESR and CK. And how to differentiate? This is how to differentiate. If your lab is showing both, CK and ESR normal, what is your diagnosis? I mean, problem in combing, problem in getting up from chair, problem in climbing stairs. These are there in all three conditions, but if they say when the lab shows ESR, CK normal, this is nothing but drug induced. If they said all of them are raised, ESR and the CK, So inflammatory, and at the same time muscle is actually involved. That is the poly. So poly means many, inflammatory, and also myositis. So myositis, so polymyositis. Is it clear, guys? Is it clear? The poly and dermato. Poly and dermato. Let's see. Our John Baba, of course, has to say something here. Should not ignore John Baba. Baba also telling the same thing. Muscle weakness, proximal muscle weakness, main complaint in weakness. I mean, of course, weakness. Yeah, joint pain things. Okay, one thing you can add here, dermatomyositis or polymyositis can cause malignancy in future. Okay, this type of associations are, guys, very important. So please mark your journal. Okay, they might be associated with rash. So polymyositis, when associated with rash, we call it dermatomyositis. Very simple. Okay, and this rash is often we call Heliotrope's rash. Also, you might find in this side Groton's papule. Okay, these are some additional findings. CK is supposed to be raised. Most cases, CK is raised, ESR is also raised. So this type of thing, one thing, let me just turn on my video for a second and just show you guys one thing, what to do here. Now, if you see this type of, what is this is called? This is called some kind of sticky notes, right? Now, if you have your own John Murtagh, say example, this is not John Murtagh, but some else book I was studying. So if this is one of the book and you are studying one of the portion, and example, the point which I just said, or maybe you can take a printout if you have printer, you take a small, scotch tape or something and you attach to that part and just add into that particular page like this into your book. All right. So that will be much easy for you in future to study. Is it clear, doctors? I mean, how to make things more effective. I work on that. I research on that, how to make things more effective. You take small, you buy next day some this small sticky notes, and those are the additional points I'm telling. Like example, osteoporosis, some points I told. You can write this type of paper or maybe a little bigger paper and you attach to your book, so that at the end of the day, I mean end of the course, when you are getting and entering into the hall or 1 month before the exam, then you will get the benefit. You might not get benefit now, but at the last month you will get tremendous benefit, because while learning we learn a lot of things, but can we take everything to the exam hall? Just think logically, no, right? So the more organized your thing will be, the maximum thing you can take it to the exam hall. And that's the motto actually. Many people actually read so many things and they cannot take it to the exam hall just because of lack of revision. And many people don't know how to revise actually. MBBS, it's very small actually compared to the AMC syllabus. It's quite small. Now you have to remember everything and go get into the hall actually in just one day. Not a like a the exam is divided into medicine, surgery, gynae, writing is separate, viva is separate. It's just one single day. So you can understand one thing: your performance, if MBBS is this level, MCIT has to be this level actually. Okay, because everything you have to remember in a single day and go and perform actually. So the more you will organize things, you will remember it actually. Increase on your photographic memory and things like that. Like, for example, why I use color, because okay, in rheumatology I used the orange colors, maybe in the respiratory I use the green colors in my books. Okay, so these are also some technical things actually in terms of the study. Okay, I hope so that is useful. Hope I'm not bothering you guys. Yes, I hope so this part and suggestion you will remember and utilize it, and do give me feedback in some classes whether the methods are more useful or not. I mean, it takes time. It doesn't mean that you will start doing tomorrow and you will start getting benefit in 10 days. It's not like that. It's like Kegel exercise, right? It will take some time to. Anyways, so guys, I mean, are we clear with dermatomyositis, polymyositis? I'm going to tell you guys one good website name where sometimes you can see sometimes good clinical scenarios, and that one's name is, let me just add here, Med Bullet, Med Bullets. Okay, You can go to med bullets and you can find those things so easily. I mean, about polymyositis or dermatomyositis, polymyalgia rheumatica, you will find very nicely. And of course, drug induced is not there exactly, but you can remember drug induced does not have any finding. Okay, I mean lab wise actually. Okay, now how polymyalgia rheumatica looks like? It will look like a elderly woman who is trying to touch her shoulder. It's kind of like that. Elderly woman who's trying to touch her shoulder because she has pain on shoulder and some other parts actually. Okay, so that's polymyalgia rheumatica. But same problem again, proximal muscle weakness or proximal muscle myopathy. So stuff getting up from a chair or whatever, I mean, combing and many other things. Additional point you can remember, jaw claudication, maybe. Additional point can remember jaw claudication actually. But anyways, when you do the lab, what is your lab finding? You will only find ESR raised, but CK remain normal. Is it clear, my dear doctors? Elderly woman trying to touch her shoulder because she has pain in these points, in the hip areas, she has pain. Okay, and only thing that is raised, as you can see, elevated ESR. Okay, so that's important. Anything with inflammatory and the things, if you use steroid, it always has good response. So you use a good painkiller and at the same time you use steroid. That's the treatment. Okay, many rheumatological diseases, I mean, steroid is a very good treatment. I hope so you know that. Okay, so polymyalgia rheumatica clear and dermatomyositis clear, everyone. Polymyalgia rheumatica clear, dermatomyositis clear, and drug-induced myopathy, is it clear? Drug-induced myopathy, you don't have much thing to remember. Drug-induced myopathy, just remember the lab finding. And also one recall will show you next day, your conception would be even more clear, you know, how to solve the, you will find, they will give you one drug name. I mean, they will give you one drug name. The person is using, you know, one drug, for example, what drug it is. Name one drug that can cause drug-induced myopathy. One drug name, please. Statins. Example, statins. If you use statin for so long time, especially if that's the combination, it's also lethal combination. If you use statin and the another one, the one for the triglycerides, in any way, if you use that combination, it's more dangerous. Also, you can add, you know, the steroid name here. So if you use a steroid for so long time, you know, it can also lead to drug-induced myopathy. Steroid has a lot of effect if you use it for so long time. 5 days using of steroid, no such effect. Long time use of steroid, I mean, very big effect. Okay, I hope so things are clear. We were discussing some of the, you know, investigations, and at the same time we were correlating with some of our diseases actually. Now one last point from the investigation, that is antibodies, right? One last point which you need to remember is from the antibodies. So I have 3 tables actually to remember here. Now one is this one. I'm sure all of we have learned what are the causes of, you know, RA positive. Is rheumatoid arthritis is the only point RA positive? No, right? That's why it says non-specific test. Rheumatoid arthritis is only one cause, I mean RA positive, but there's many other causes, like even SLE it can be positive, extreme elderly it can be positive. So there is a big list we can see, right? Where, sorry, this one, RA can be positive. And also ANA, is it a specific test or non-specific test for SLE? ANA, anti-nuclear antibody, it's also non-specific test. So it can be present in some other diseases too. SLE is just one. It can be present in Sjögren's. It can be present in, you know, systemic sclerosis or dermatomyositis. Many other conditions. It can be positive. Okay, so you have to know these charts well actually. Next is coming is actually the antibody name, specific these antibodies. You need to remember it actually. This chart is also present in John Murtagh. This chart is also present in Davidson. You can use any one of them. But why I'm using the Davidson one? Because they asked one question and it was not present in John Murtagh, unfortunately. Okay, and what was that one? That one was, let me show you. Antihistone antibody. Does anyone know here antihistone antibody is related to what? Might be a little tough question for some of you. Antihistone antibodies is very specific from drug-induced SLE. Okay, so that's like a drug-induced SLE. Okay, some of the doctors, I mean, yes, please allow the previous doctors to, answer the question. Okay, some of the doctors, please allow the new doctors to answer. Or actually, it's not, I mean, because you guys performed, your chance was gone last batch, not here to perform. Actually, the one I already told you, and telling here is not a very big deal actually. So those are new here, I mean, if you're answering, that's better actually. If you're from old batch, it's no benefit of answering again and again here actually. So anyways, drag into, you keep it to yourself would be better actually. Yeah, sometimes you don't have to be too fast answering that. You hold your answer. Some of you, whom I'm telling, I hope so you are understanding. Okay, so thing is, this antihistone antibody, this name, and the remaining ones are present in John Murtagh. So antihistone antibody is related to drug-induced lupus. Now you need to know what three drugs, and only new doctors will answer, what three drugs causing antihistone antibody. Now it's like three drugs, and their name is, who remembers that song? Hips Don't Lie. Okay, very nice song for some dancing actually. Hips Don't Lie. I mean, I hope so everyone knows the singer. I'm a famous singer. So that hips don't lie, actually that HIP, hip, we like to take it as a mnemonic here. Famous mnemonic. How many of you have seen that song? No, it's a World Cup song. Or, yeah. So hydrolazine, INH, isoniazide, procainamide. There will be one, two more names could be there, but we just remember the hip or hips don't lie, whatever you remember. The famous song by Shakira, actually. So hips don't lie, actually. Okay. So these are the drugs can cause drug-induced SLE and anti-histone antibody positive. Now, suddenly why I'm starting with that one? Because this is something which has been tested in AMC before. And if I just want to add that chart, autoantibody chart, so please check it here that, yeah, initially it was written that these things will be taught from Davidson. I mean, we have already taught. Now this autoantibody, which is given in page number, you can see 313. 313 is the page number. Okay, so it's also given, but do you see any kind of antihistone antibody in this page? 313 page, guys. Not really. So I add that one separately. See, antihistone antibody, and that one drug-induced SLE. So only one was not there, and they came up with asking a major question from that one. So sometimes they also like to do trick. So these are the parts, guys. We have to be a little careful sometimes, because most people, I mean, those are making questions, they know that you are blindly following John Murtagh. So sometimes they make one, two question outside the John Murtagh too, actually. And yeah, but don't worry, we are aware of their strategies actually. That's the thing. So since we are talking a little bit about SLE and drug-induced SLE and hips don't lie and SLE, so why don't we finish SLE? What do you think? Can we do little SLE here? Yes. So we have that SLE here already, one of the condition you like to study a lot. Now, my question to all of you, and if you want to think, what is the most common feature of SLE? If you just want to think, you will find young female who is having feature of fatigue. No, butterfly rash. How many butterfly rash you have seen in your life with SLE? Very less, I mean, to be honest. The butterfly rash, is because we are taught butterfly rash, but not always the butterfly rash is the main. One of the main thing you will find, they might having mood swing, they might not feeling good, and mostly it's fatigue. They said, we are not enjoying anything, we are feeling fatigue. Many times we think this is depression case, and it turned out to be, simple fatigue. I mean, initial complaints are fatigue. Later, the other problem started to come. Yes, someone said menstrual, yeah, now you are talking. because these are common areas that's got affected. So feeling weakness, feeling fatigue, I'm not enjoying. So these points you need to consider. Then your questions will be, have you realized you go to light this stage and you have some skin problem? I mean, I'm talking about what? Photosensitivity. Then have you noticed any kind of rash in these areas? Then draw butterfly rash and fuel talia, you have noticed 1 2 times. This is how you need to start. So this is about the SLE. SLE has 11 criteria. I mean, I don't want to get into the criteria. I mean, I'm sure all of you know about the SLE criteria. So rash, sensitivity, light, oral cavity involvement, blood-related involvement, neurological involvement, kidney involvement. Um, Lupus nephritis is nowadays is a very interesting topic to do some research. If you want to make a research project, lupus nephritis it can be. Okay, lupus nephritis is means like advanced stages. Your SLE has uh, went so far, I mean, to more advanced stages. Okay, one more thing, SLE can cause recurrent abortion. How? By in relation with another condition which is called antiphospholipid syndrome. It means when you see a SLE patient, you should also rule out antiphospholipid. Agreed? When you see SLE, SLE itself has thromboembolic manifestation. SLE also has a lot of time, maybe 20-30% time. It has relation with antiphospholipid syndrome, if you have realized that. Okay, so antiphospholipid syndrome, this is one of them to remember. Antiphospholipid syndrome, it will come in gynae again, but remember one thing, it will increase chances of stroke 30 times more. Please just write near to your journal. Antiphospholipid syndrome has 30 times chances of stroke. And of course, it's one of the conditions related to abortion. Better to add recurrent, that word. So recurrent abortion and increase 30 times of stroke by thromboembolic manifestation, better to say. Okay, so they are interrelated. So oral cavity, kidney, neurological, like neurological what problem? Psychosis, they're not enjoying, they might get irritated, aggravated. And of course, immunological feature means what? So come on, ANA is a initial test, but how to confirm it? And that's the immunological feature you need to know. That is what? That is anti-DS-DNA. Anti-DS-DNA. So ANA is the initial test, anti-DS-DNA is a confirmatory test. Antihistone antibody is a drug-induced SLE test. So three things. I repeat, guys. So there is like three things for SLE cases. That is, one is that simple test, initial test ANA, confirmatory DS-DNA. But if they say drug-induced, if they say drug-induced, anti-DS-DNA. Everyone clear? Everyone clear up to investigation? Everyone clear? I will switch to treatment now. We gone through clinical features. We have discussed investigations. Now we are going to treatment. Now in the next page, you might find clinical features with the picture given. You can read it by yourself, but we need to know treatment. Now previously we just learned one type of treatment. I'm sure you learned about treatment of SLE and you just learned one specific name, I guess. But now at this stage, you have to learn mild, you have to learn moderate, you have to learn severe in that way. And you also need to distinguish between mild, moderate, and the severe. If it is said renal involvement, is that mild, moderate, or severe? What do you think? If it is said kidney involvement, it's not a good news, by the way. It means a bad news. It's a severe. Okay, initially fatigue, ANA positive, DS-DNA, but not so much symptom, that's a mild case. If it is progressing, you give normal drug, it's not working, this is moderate. So initial treatment failure cases are the moderate cases. Clear, guys? Initial treatment not working, those are the moderate cases. Now you need to know what is the treatment of mild. Mild, we all know we start with simple painkiller because SLE is a condition which is, I mean, we are discussing in rheumatology, and of course, It's one of the cause of polyarthritis. Agreed, guys? I mean, there are some causes of polyarthritis. There are some causes of monoarthritis. Gout, monoarthritis. Rheumatoid arthritis, SLE, these are causes of polyarthritis. Okay. So mild cases, we go for the simple NSIs because you might find only Na positive and the SDL positive in these cases, but no such extreme clinical symptom except for some pain or fatigue. Next coming, you give NSAID and things are not improving. So now what you have to do what? You have to go through hydroxychloroquine. I'll show you a recall how it might be looking like in this case. So just give me a second. All right. Yes. Now we see this one as a young lady with SLE, with facial rash, with arthalgia. I mean, common thing. Butterfly rash, pain in the joints. Patients not, I mean, not having good compliance with the current drug. Current drug means what? NSAID. All right. So what else to prescribe? I mean, is it now currently, correlate with the, information I gave for moderate case? I mean, is it moderate case? Is it severe case or what? I mean, I told how to diagnose moderate case. When initial treatment is not working, we go for moderate case. Clear? I mean, you have to remember what I say actually for AMC. It's not like you might have very good knowledge, but every exam has its own beauty, own tactics. You have to remember the terms actually. So initial complaints, I mean, there are complaints, initial drug is not working. So that means that you need to go for second line. Second line means the moderate here. So for moderate treatment here, it is hydroxychloroquine. Is it clear, my dear doctors? Is it clear? I mean, those of you answered this one as severe, you need to be understanding. We don't jump into the severe treatment. We never jump into severe treatment always. Okay, initial not working, we go second line. If everything failed, then we can go for the final actually. And there are some signs of the very severe one. Okay? Like here, kidney involvement can be there. Kidney involvement and these things can be there. Now, SLE is an autoimmune type of disease. Will you agree with me? SLE is an autoimmune type of disease? Yes. So most of the autoimmune type of disease, when you want to treat acute condition, we have to give steroid. Agreed? Any autoimmune disease, acute flare-up, we have to give steroid. Yes. But as a maintenance, you have to give a lot of other things too. So we either have to give NSAIDs, either have to give hydroxychloroquine, either we have to give treatment of severe. Is it clear? So short dose of steroid, a bolus dose of steroid, along with making a staging, I mean what stages of the disease is, and give the treatment accordingly. And if it is anywhere drug-induced SLE, what will be your treatment? Okay, interesting question, right? Drug-induced SLE, what will be your treatment? Drug-induced SLE, you need to stop the offending drug and also painkiller, because pain would be there. Pain is real, right? So stop the drug and give some painkiller. All right. I hope you enjoyed the SLE one, my dear doctors. Is it clear, SLE? A little different, right? I mean, what we learned in MBBS, I mean, little bit one step ahead things comes actually. They talk more about investigation. They talk more about the treatment nowadays. I mean, at this stage actually. Okay, so followed by, let's finish two more diseases that's also common in female. By the way, guys, most of the diseases in rheumatology are related to female, right? Except gout, ankylosing spondylitis, some of those diseases. Okay. So two easy conditions. I mean, one is the systemic sclerosis, and one is Sjögren's coming up. So systemic sclerosis is basically how to understand there is systemic sclerosis. I remember I found a patient, I mean, female. Sometimes we go to ward to check and think. I found The skin is very shiny and tight. Now, have you heard this kind of condition before? Thick and shiny skin. Of course, I mean that female is not that category of can able to bear the cost of manicure. I mean, if a other female came from very high society and doing manicure and is shining, that's a different thing. But that's a very poor socioeconomic condition, and it's very thick and shiny skin. It was scleroderma, actually. It was systemic sclerosis. She actually came for pain. I mean, mostly how it was treated. But a female, a bit elderly, coming to you and you're thinking osteoarthritis treatment of also, it was given a treatment of osteoarthritis. Later I figured that when I asked my professor and he said, okay, we'll go for more investigation, good finding. So then we do the testing and it came out that it was systemic sclerosis actually. Now, you can tell me one thing, what are the tests we need to know? What are the tests? Okay, N is one of them. Of course, N is one of them, but NA can be also positive in SLA. NA can be also positive in scleroderma. We need one more test. What is those tests are? Have you heard about La and Rho? Or anti-topoisomerase, maybe? Okay, so either they will give you anti-centromere or topoisomerase, either they will give you, that La and Rho. But La and Rho is more probably goes with Sjögren's. If I show you a picture, so better to remember is topoisomerase. And for Sjögren's, two birds are shouting here with La and Rho. So for Sjögren's, La and Rho, I just want you to remember this picture, shouting with Rho and La, whatever it is, and this female is watching like a maybe some cartoon and like shocked, and eyes looks too much prominent because it's dry. Now dry eye, dry mouth, and La and Rho positive, this is a condition called what? This is a condition called Sjögren's. Well done. You can also do litmus paper test for Sjögren's. Not only blood test, you can also do in the eye, you can also do litmus paper test. I mean, checking the dryness level. Shimmer test is called. Shimmer test. That's also one of those initial tests actually. How to confirm Sjögren's? Now that's an interesting question. How to confirm Sjögren's? Innocent and simple question. Many of you will answer like La and Rho. It's not. It's not. La and Rho is also kind of like some of those initial or supporting tests. How to confirm? My question is how to confirm Sjögren's? Answer for that one, you have to take, yes, well done, some biopsy. No, shimmer test is initial. I told you again, shimmer or blood test are initial. You need a biopsy. Where? Biopsy from parotid gland, because gland is affected here. So parotid gland biopsy. Many times we don't take it because we get to know by clinical and blood test. All right. So parotid gland biopsy. According to Master the board, it's written parotid gland biopsy. All right. So this is something about the Sjögren's. Is Sjögren's clear? Dry out, dry mouth. Two birds are shouting near to you, La and Rho, and the woman is shocked with a dry eye. Right? Not that tough, easy. And last but not the least, there is one thing that is called crest. Have you heard this name before? Crest. So crest is, these features are present in case of systemic sclerosis. So Raynaud's can be one of those features. Raynaud's, by the way, guys, is not a disease. Raynaud's is a clinical feature of many of those presentations. Raynaud's actually can be primary. Raynaud's can be secondary too. So this is a secondary cause. I repeat, Raynaud's is just a symptom. It's not a disease. Here, it's a secondary presentation, not primary. Right? So calcinosis, Raynaud's is a feature sclerodactyly and telangiectasia. These are the certain features, all right, for systemic sclerosis. So Crest is a toothpaste. How many of you know that? There is a, I mean, if you are in Australia, you should know by this time. There's a toothpaste available. I think one of the very commonly give offer, right, in Australia. I mean, if you go to the shops, Wool's, Coles, whatever the shop you go, you'll always find, there are buy one get one or 30% off with Crest. It's common, right? All right. So that's the thing. So here you go. I mean, it's given here systemic sclerosis. Systemic sclerosis, some clinical features are given. I mean, you will also find weakness, arthritis. See, all those conditions we'll be talking today has arthritis because it's a rheumatology topic. Apart from that one, please remember Crest. Can you do that? I mean, I want you to, do this thing. I mean, take a little this paper and later, not now. I mean, and write the Crest abbreviation and paste it to your book later. Actually, I hope you can do that right later. So the Crest syndrome, the symptoms, you can write it and you can just paste it to your book. It will look more complete. But I think it's given. Crest is given in the next page, I think. Yeah, it's given in the next page. So probably you don't have to. Yes. And investigation, anti-centromere, anti-topoisomerase, or anti-SCL, whatever you say. Treatment, of course, analgesic, and these things you can use. And interestingly, calcium channel blocker and D-penicillin. Calcium channel blocker and D-penicillin, you can use it actually. All right. So these are the 13 points you can use here. All of this, guys. So this is something from the presentation for this condition. So can you go for a little break here, I guess? I mean, SLE, systemic sclerosis, Sjögren's. I mean, some of these SSS, I mean, have been done. So we'd like to go for a 10-minute break here. So if you guys allow, so thank you so much, guys. So we're going for a little break. SLE mnemonic, yes, you can just go and just Google it. You can go and just Google it. Few things you have to do it, right? Everything is not a spoon here. You know it, like, you have to find it. Oh, yeah, so brain, these are baby things. I want you guys to be more self-dependent. Okay, break, 10 minutes. We'll be back. So thank you so much. We'll be back in 10 minutes. Thank you. All right, everyone. So we can start shortly, I guess. All right. Is the screen is visible? I guess yes. Okay. So we were discussing rheumatology and we were in a break. So we'll be starting in just 1 minute. Please let me know if you can, see the screen actually. Just for confirmation, do let me know. Okay, thank you for confirmation. And also, happy Easter to those doctors are celebrating. And sorry, we forget to give vacation this time actually. I mean, while scheduling, but we will be uploading the recording tomorrow and we'll keep it for this whole week. Okay, so that's one of those news I can share and do for you, that the rheumatology one would be available for whole 7 days actually. Okay, so that's one of those news. Those are, this is a very big festival for many, I know. So just something I can do from my side actually. All right, so we're discussing rheumatology. We were discussing some of those basic clinical correlation, John Murtagh, highlighting major diseases, and of course after class exam that will be coming up. That's the plan for today. And today's agenda would say, like, 4th of April, it's like, Esther, and something to remember for some doctors. I really wish, and I just hope some of my dear doctors are not in that position. Some of them are left today, I think maybe 5, 10, but I mean, that's okay. 80 plus is here as well. 10 left maybe today does not want to take any risk today. But anyways, no problem. We were following books like John Murtagh, Davidson today, and today some of the agendas were rheumatology theory. Okay, one thing I wanted to know, some of you haven't still got study partner yet, so guys, please try to get a study partner as soon as possible. My humble request to all the doctors, it is, some people ask me personally, is it necessary? Yes, it's necessary for you. It's not MBBS. MBBS, it is very much possible to pass without a study partner actually. So if you don't have one, how to get it? The way to get it, you can uh, go to the Facebook, then enter into batch 38 and 39. Whoever you like, you can send request and become study partner. I mean, just joke apart. But you can also, I mean, post in our secret group like you are looking for a study partner, and keep repeatedly post there actually in our secret group. One more thing, my dear doctors, I mean, I realize you guys are studying a bit less actually. The previous batches used to discuss more in the secret groups actually. Even the same questions, sometimes you can also discuss. Okay, so two things will happen. To see other studying, some other will study. So people like to follow people actually. Okay, so that's one of those things actually. So we have posted in past actually, and now you guys can also post and get a study partner from our secret groups and also guideline groups actually. Yes. If you make a study partner from outside of our courses, make sure, I mean, our major slides and the things, we have policy of sharing and these things. So you have to be really take care of those things actually. Okay, in past there was 1, 2 doctor has been suspended because of that kind of thing, because if something is related to class, you really cannot share. Of course you can type and share your knowledge, but not like exactly class slides, recall files. You cannot do that in that way actually. We have policies on that one. Okay, rheumatology theory, study partner one dedicated is very important, and study group. Some people ask me, doctor, is it like a 20 people, 25 people? No, not really. For 25 people, 20 people, and Bigger groups, you have guideline group. You can follow very easily the guideline group. You can now, from now on, every doctor has to post at least one question in the guideline group every weekly, and has to take part at least on 5 questions. Question means like, okay, I think the answer is A because this is the reason. Okay, so please bring this thing your own practice. Believe me, this is a very good way of communication and discussion actually. Sometimes you might not see what is coming up, but we can see because we have gone through this process. This is a evidence based. This is practically proof. Whoever active more in the forum, got not only pass, they got good marks actually. Some of the doctors you will see very active, like you see Dr. Griffin, Dr. Pramila, many others. They are like I mean end stages of their preparation, so they're very active. So I want some other people to get active, similar like them. Some others, I mean, I'm not taking everyone's name, but there are many others also very active. So be active like the active people actually. This is really evidence based, and it will be really fine actually. All right, so that's the thing. And secondly, I mean, yeah, some summary will come later, that's okay. And these are some of the points I like to tell all of you actually here. Okay, so I'll be going to share my screen again one more time, so that's okay. Just give me a second. I'm just taking a second before I share my screen. Let me open the book for you. Do let me know if you can see my screen actually. No. Yes. Okay, so guys, we were discussing SLE, we were discussing Sjögren's where like a dry, everything is get dried actually, like that's Sjögren's, and systemic sclerosis, that is CREST syndrome. By the way, before leaving guys, CREST syndrome is actually limited variant, and there is also diffuse variant. If those want to know a little bit more, you can search in the Google by what is systemic sclerosis, or what is diffuse variant, what is limited variant actually. We actually don't need that much for AMC, but those who wanted to read that, you can go and read diffuse and limited variants. It's also available in Davidson actually. They also discussed by diffuse and the limited variants. CREST syndrome features are mostly present in limited variants actually. Okay, so these are the few things. In SLE, we also discussed about clinical feature, investigation, and the treatment. Now we are entering into some more things that's been coming up shortly now. The Raynaud's phenomenon, which is something we were discussing, I mean, because it came often as a clinical symptom, right? It is something tested as a clinical symptom. Now, it can be that Raynaud's, that one slide will help you with the Raynaud's phenomenon. Earlier, what I told, that systemic sclerosis is an example of primary Raynaud's or secondary Raynaud's. I just want to remind you that one. Systemic sclerosis is an example of secondary Raynaud's or primary Raynaud's, if you can remember. It is a cause of, I mean, secondary Raynaud's, if you can remember. Okay, so some of you see quickly forward that one. You have to remember the important things. Now, how this question can be tested regarding the Raynaud's phenomenon? Here is a question. I want you guys to take a screenshot or picture with a mobile, whatever you like. Okay, so I'm giving you 10 seconds to do that. So Raynaud's is an important topic. It's not a like nice to know. It's an important topic here. Now, how question can be tested? Now, because it's not a common thing we learn in MBBS. So often, doctor, how this can be tested? This is how it is tested. Let's see the question. But before that, you need to take a picture of that one. Okay. Now coming to that, how is the question is given? 25-year female complaining of Raynaud's phenomenon. Okay. How Raynaud's phenomenon? There is color changes in the hands. Some color changes in the hand actually. That's like the Raynaud's phenomenon. In exposure to cold. It's occurring in 3 years, for 3 years after a lung infection. When you see the lab, ANA negative and ENA negative. Now, what could be the main cause? Primary Raynaud's, scleroderma, SLE, limited sclerosis. Now, the previous doctors, please avoid answering first. The new doctors, what do you think? Now, out of this A, B, C, D, which one do you think can be the answer? You just attempt one, that's fine. It's okay to be wrong. It's okay to be wrong, guys, sometimes. Okay. So many of you are answering A, some of you are also answering B. Let's go and explore this condition. Why is it A? Is it A or is it B? First of all, let me add that one. Our answer is actually A. Now I'm going to explain why the answer is A, primary Raynaud's. Now primary Raynaud's includes, if you see primary, less than 30 years. Our age is 25 years. Is it a symptomatic? I mean, symptomatic means what? Symptomatic means organic disease is there. It doesn't mean that only Raynaud's symptom. You got my point? Symptoms mean other system disease, like systemic sclerosis has CREST symptom. SLE has its own 11 symptoms, right? Is in this question that kind of symptoms are present? What do you think? Is there any SLE type of symptom? Is there any systemic sclerosis type of symptom? No, right? It's not present, right? So it is asymptomatic. Raynaud's is the main feature, but you need the other features to call it symptomatic. So this is asymptomatic. Clear? Next, autoantibody is present? No, negative. Okay. Panel testing also negative. Panel testing means actually the ENA means a panel test actually. Okay, so that's also negative. So now you, those of you answered B, what do you think? Is it the answer A or is it the answer B? I'm sure all of you will change your answer to answer A now actually. Okay, this is the way to differentiate. This one question mostly comes, my dear doctors. This is the only one question that comes from Raynaud's mostly. Clear, guys? I just try to make it more easy, everything. But only telling people don't get it without question that, you know, what I'm trying to say actually. Now, one more thing, panel test. Panel test means ENA. ENA means panel test. Panel test under that ANA or other autoantibodies, those are there. I mean, all autoantibody panels are called ENA actually. All right, that's been panel test actually. Nothing. I mean, ENA is also kind of like a panel test. A bunch of rheumatological tests all together called panel test. Clear, guys? A bunch of rheumatological tests all together called panel test actually. So panel tests are negative actually. All right, so this is the thing. So age, autoantibody, and symptoms all together we call it primary. Okay, next one thing. If it is secondary, which secondary is more common? That can be another question, and it has been tested. Now you will be given a lot of offers here, scleroderma, SLE, any ideas that which one is more common? Now for that one, to be honest, the more common is the SLE. SLE being more common than the systemic sclerosis. 70% is for SLE, 20% is for systemic sclerosis. So if both options are given neck to neck, you should choose the SLE, depending also on the symptoms and, you know, so on other things. Okay, is it clear, my dear doctors? I mean, I hope so we can leave this part. Okay, so we have to do some more things coming up. So Raynaud's phenomenon, are we clear now? See, I mean, very less information they have given, but if those just follow the John Murtagh, they actually don't able to answer all the tricks of MC, isn't it? Do you think that question is possible to answer from this Raynaud's, what is given here in John Murtagh? I'm sure it's not possible actually. Now, what is your job here? Your job here is to, you know, take again this, you know, pen and paper type of thing. Again, I'm back with that one. Again, take pen and paper, things like that, you know, draw that one and paste it to your book. Okay, there's a different book. Okay, which book is this? Anyone knows? Any idea? Long back, I think. Okay, I think you have seen it already. Now the names. Try to guess it without the name. Yes, that's okay. It's my next 5 days project actually. I'm going to read my own hematology knowledge to furnish a little bit more actually. I thought I forget few points actually. Okay, normally I have very good memory power, but I am feeling like, you know, this one I have read, I think 5 6 years back. So I just need to finish this one in next 5 days actually. Anyways, I mean, you know the faster ways to study. Okay. Next coming up, the topic Raynaud's is done. Okay, about vasculitis. About vasculitis, guys, is mainly I will post 3 slides for you after class. You just have to go through them actually. Vasculitis. Mainly, there are 3 slides which I'm going to upload for you. Not everything is necessary. I repeat, not everything is necessary from that slide. Okay. Mainly, you have to learn one very major thing that is actually that's an eye topic though, but it also overlaps here. That is giant cell arteritis. Okay. Giant cell arteritis is something, it's also known as temporal arteritis. I'll tell you clinical feature of temporal arteritis. It's mainly, uh, there will be arthritis, there will be headache, and there will be vision loss. Okay. So temporal headache with vision loss, with arthritis, some cases jaw pain as well. So altogether, my dear doctors, this is giant cell arteritis. Number one important thing here is what is the treatment? Are we going for investigation first, or are we going for a very quick treatment here? So our answer here is we have to go for, you don't have to take picture of this one. I will post this one. Don't worry. Vasculitis slide, I will post it. So we need to go for a high dose of steroid without any delay. So our initial test is ESR, as you can see here. Initial test is ESR. How to confirm it? Temporal artery biopsy. Okay, what is the consequence of waiting here? You know, you might lose the vision. If you don't give high dose of steroid, the patient might lose vision. And is this reversible or irreversible? This is an irreversible blindness can happen. There's a lot of cause where there can be reversible blindness. But this blindness, my dear doctor, this is irreversible, permanent, yes. Now I remember vasculitis as large, medium, small vessel. The large vessel vasculitis is R. Okay, so the large vessel vasculitis is R. Giant, TACA. Anyways, I mean, TACA you guys know now actually because you have taken admission. Just joke apart. So the currency in Bangladesh is called TACA, right? So, and giant means large. So giant TACA. So large vessel vasculitis, giant TACA. Please remember in that way. Okay, easy to remember. TACA so I haven't seen coming, but those interested, you can read it. As I said, I'll post this slide later. Next, medium vessel vasculitis. 3 conditions here actually. Polyarteritis nodosa, Kawasaki. By the way, guys, Kawasaki we are not entering here. Kawasaki is our pediatrics topic. Okay, a baby who is having, eventually, lymph node enlargement, red tongue, redness of the eye. Okay, so and heart problem eventually. You need echo for that actually. So that's Kawasaki disease, IV hemoglobin. I will talk more about that one in pediatrics. But just as you don't need it. But polyarteritis nodosa, my dear doctor, among the medium vessel vasculitis, you have to remember. Often, polyarteritis nodosa can be associated with hepatitis B. Interesting point. Polyarteritis nodosa can be associated with so many other systemic problems, including renal damage. So many other systemic problems, arthritis, kidney, high blood pressure, many things. But kidney damage you also should remember more actually. Now, what might be tested from polyarteritis nodosa? More. Okay, more thing that can be asked is actually investigation. So I will be showing you something interesting from, we call it often PAN actually. All right. This is how a question of PAN looks like. 43-year, I mean middle age, hepatitis B or C, complaint of severe chest pain, lean back, and physician notes some skin marking and things like that. Okay, this is actually called something levido reticularis, but anyways, it's a complicated thing. You don't have to go that far. So multi-system and hepatitis B, C, rheumatological and skin problem. It can be polyarteritis nodosa. Now, what to remember from polyarteritis nodosa? I suggest you to read it from master the board, my dear doctor. Okay, because right guidance is also important. So I want you to open the master the board and check 295 page for polyarteritis nodosa. Now, what they will, how approach and what question will be asked? It will be asked like, what is initial investigation? What is confirmatory test? So initial, no doubt, it's some kind of inflammatory things are there. So ESR is in initial. The most important question that comes, how to confirm polyarteritis nodosa? Have you heard about sural nerve, my dear doctors? I mean, I even remember in 2016 when I take my MC, this question also came. Also, it's been repeated a couple of times. Does anyone know where sural nerve is situated? A little anatomy. I mean, where is that? Does anyone remember? Now, answer for that one is it's in between two gastrocnemius muscle. Leg will not be. I mean, leg is too huge. So two hedge of gastrocnemius, right? That's the answer actually for sural nerve. So not an easy biopsy. So either they will give you renal biopsy or the sural nerve. One doctor asked me last time, doctor, if both are given, then which one? Now, both of them are accurate test. If both are there, then sural nerve is a better choice. I repeat, if both are there, sural nerve is a better choice in that case. Clear, guys? And one time treatment has been asked. I mean, they gave a clinical scenario and they eventually asked the treatment. So treatment, it was mentioned, I mean, cyclophosphamide. So the treatment was cyclophosphamide. Also, if there is underlying hepatitis B, you need to also correct it. Okay. So please take a picture on that one and use it later actually. Yes, sural nerve. I mean, more specific. You see, kidney and that sural is a very specific. Kidney biopsy, for a lot of diseases. Sural nerve is specific for this polyarteritis nerves. Okay, that way. Sometimes we have to be little, tactical. I mean, just a little tactical. Well, kidney biopsy, all kidney diseases, right? All kidney diseases, kidney biopsy. But sural nerve is very specific for polyarteritis nerves. That is the reason only. But both of them are very confirmatory. It's very much confirmatory. Okay. So here is a reference. I mean, it is a polyarteritis nodosa, clinical feature given, sural nerve, frequent location for biopsy. Clear now? Clear now? I hope so. Yes. All right. So this is one of those medium vessel vasculitis. So three names: polyarteritis, Kawasaki. Kawasaki being 5-star, it will be taught in the pediatrics, don't worry. And but just remember it's okay. And last but not the least is small vessel vasculitis. By the way, this vasculitis pictures I will be posting, don't worry. Okay, so something Wegener's. Do I have to need to again tell about Wegener's granulomatosis? Wegener's, I think we know by this time, there will be respiratory and renal involvement. I repeat, respiratory renal involvement and Sianka treatment with cyclophosphamide again. And there is Henoch-Schönlein purpura. In Henoch-Schönlein purpura, it's a non-blanching rash. Keyword for Henoch-Schönlein purpura, non-blanching rash. Secondly, the rashes are from leg to buttock. Clear? The rashes are from leg to buttock. You can Google it to see how the picture looks like. Leg to buttock rash. It's kids, and purpuric rash does not blanch on pressure. So also, I mean, that has some association with kidney problems, right? This Henoch-Schönlein purpura. You can also check it from med bullets. Okay, so these are all those type of vasculitises. Among the vasculitises, Wegener's is more important. Henoch-Schönlein is basically pediatrics topics. Polyarteritis nodosa here important. Kawasaki goes with the pediatrics. And this one, giant cell arteritis. Clear? I mean, I hope so we are clear, I mean, with some points. All good, guys? Understandable? Okay, so vasculitis is a topic for renal, also somewhere for rheumatology. Okay, I try to give you a clear view actually. We'll be posting the recording tomorrow after 24 hours. You can review it again. If something you don't understand, you can review it again. Coming back to original, so these things are done, vasculitis things are done. Giant cell arteritis, see giant cell arteritis given in John Murtagh, page number 318 page. 318 page. You can check it, the giant cell arteritis, but the main points I have told you guys already. Okay. One more thing, a nice to know topic, Behçet syndrome. I know it's might be a little complicated, Behçet's. It's a nice to know. We just remember two things, one mnemonic and one treatment. Treatment for Behçet's is steroid, mostly. If not working with the steroid, disease modifying anti-rheumatoid drug. Now, DMARD is also used in rheumatoid arthritis, but also used in some other conditions too. Okay, treatment is clear for Behçet's, but what are the clinical scenario and who can tell me about the mnemonic? Now, old doctors can also tell about the, that Behçet, the spelling is different, Behçet syndrome. So there is a mnemonic. Does anyone remember from previous? Well, now it's your test. Some of you wanted to, write a lot. Now, what is the, yes, well done, Dr. Rashid. Now, it's a something related to middle-aged male disease, middle-aged male. So think about a little STDs here. Okay, so R for this word, recurrent, oral and genital ulcer. Ulcer, clear? U for what? Urethritis, or maybe better to say uveitis. Is there any uveitis here? Ocular problem? Yeah, vision and a lot of things affected. All right. So, and what is AS stands for? What S stand for? If you add STDs, that's also okay, but anything you can add more, just have a look. It's mostly, I'd say, skin problem rather than STDs. This is one of those key findings, and that is erythema nodo. That was the line I was looking for. STD you can remember, but this one also you can correlate with STD, recurrent genital, somewhere related to STD. And last but not the least, this T is for a test. There's a pathologic test, positive pathologic test. Okay, so that's for the Behçet's. So one mnemonic, one test name, that is pathologic test, and the treatment is, I'm sure you all get it now. So it is high dose steroid. If not working, DMARD is clear. Are we clear with the Behçet's? I think it's very easy. Okay. And in the next page, that's okay. I mean, it's not always necessary. You can diagnose clinically. Okay, that's the thing. You can actually diagnose clinically. That is the reason, nothing else. Okay. To be honest, a funny story let me share with you. Because in your early days when you finish internship, you were enthusiastic. So in the word, I was suspecting one of them because I was preparing for FCPS. A lot of uncommon thing comes in mind. So I was about to do, asking my registrar and the thing, can we do pathologic test? And they said no need actually. Professor said it, Behçet's, it's fine actually. We don't have to go that far actually. So you get my point. Not every clinical condition we have to always come up with test actually. Okay, so if those points are there, for example, you find 3 points almost actually, so you can even make a clinical diagnosis as a Behçet's actually. You don't always have to go for pathologic test. That's the thing. So John Baba that's okay. Anyways, Wegener's, I think we already told, arthritic problem, at the same time respiratory and GIT. It's an autoimmune disease. cavitary lung lesion, C. ANCA positive. So we have discussed it. So these were a few of those points which we wanted to discuss. And we get through, I guess, discussing these connective tissue problems, right? So we are done with the chapter, connective tissue and some vasculitis problem. Okay. Now I'll get into another one. A big one is coming up. Two big one is coming up actually. Let's finish. Now, two differentiating point. One is seropositive arthritis. One is seronegative arthritis. What does it mean, guys? Seropositive and seronegative. Please open up your page number 318. Page number 318. These are seronegative. So I'll take a pen paper. I'll be just taking 15 more minutes, maybe 20 minutes. So guys, so as you can see, seropositive. One is seronegative. Can you tell me what are the seronegative conditions? Seronegative means one, Rh, negative condition. Seropositive, Rh, positive condition. So one Rh positive condition like rheumatoid arthritis maybe, or many other things, but seronegative. So seronegative is this antibody basically we are talking about seronegative. So we remember as a mnemonic, you can remember as a pair or you can remember as a mnemonic rate actually. So R for reactive, A for ankylosing, B for psoriatic, E for entero. So any of these mnemonics, whichever favorable to you. Clear, guys? So among them, enteropathic, you don't have to study here. Okay. Psoriatic arthritis is nothing but arthritis plus skin lesion, basically a derma problem actually. All right. And distal interphalangeal joint that is involved, you need to remember. It has the X-ray finding. That is another key thing you need to remember for psoriatic. What is that? What is that X-ray finding of psoriatic arthritis? That is pencil in a cup. Pencil in cup deformity. Please remember that. Pencil and cup deformity. All right. Clear. And of course, if it is something about only arthritis treatment, you can go with NSAIDs and relevant drug. If it's a skin problem, psoriasis skin treatment is different. Okay, so that's a dermatological. So we don't have to bring it here actually. Okay, so okay, this is also a bit less, I mean, important compared to others. The most important one is here is ankylosing. That comes so often in the exam. Okay, we'll come back to ankylosing. Before that, we have reactive. So the one we are taking right now here is reactive. Can anyone tell me a very famous mnemonic of reactive? Famous mnemonic, yes. Can't see, can't pee, can't climb a tree. Many of you might be learning this one even in MBBS. Okay, this is not my mnemonic. It's a very old popular mnemonic. Can't see, can't pee, can't climb a tree. What does it mean? Can't see means eye problem. So there might be uveitis or other problem. Can't pee, that means urethritis. Can't climb a tree means polyarthritis. Okay, often the age group is young to middle age group. STD histories often, and there might be some history of diarrhea or upper respiratory tract infection by some of the organism like Campylobacter jejuni or this type of thing. Okay, so let me show you something about reactive. Yes, here you go. Nice mnemonic, you will love it. Conjunctivitis, mainly conjunctivitis, urethritis, and arthritis. Some of those, organism we like to highlight here. Campyllo is also there. I mean, in another book I've seen, Salmonella, Shigella, Yersinia. Okay, somewhere it can be chlamydia because it's more over related to STDs as well. HLA-B27, yeah, that it can be. Conjunctivitis, urethritis, arthritis. Conjunctivitis, urethritis, arthritis. Clear, guys? Not a tough one. It's, I guess, the most easiest one of today, right? Can't say, can't pray, can't climb the tree. I hope so. People are busy, I guess, taking the snap. I hope so. It's available in Google too, guys. Not a very huge, uncommon one. It's quite a common one, actually. Okay. Next coming is among the seronegative ones is the one ankylosing spondylitis. It's seronegative, so Rh negative. It is associated with 6A. Now, can you guys tell here? I mean, now I am to see my dear doctors from previous batch, those renewed and joined again. Do you remember the 6A? Or maybe all of us can try together. Let's not take much time on this one. So please, attempt at least with 1A. Let me bring it out by this time. Okay, arthritis, but where are the others? Well done, arthritis. Then we'll tell remaining dear. Okay, so here is that. Well done, apical fibrosis. This is a good answer, really. Arthritis, some cases anteroaxial subluxation, anterior uveitis. This is you really have to remember. Arthritis, eye problem. Arthritis, eye problem. Please consider always ankylosing spondylitis along with the giant cell problem. Apical fibrosis, amyloidosis, aortic regurgitation, aortitis, AV conduction, so heart problem. Lots of A. Lots of A you will find here. Okay, so ankylosing spondylitis. Clear, guys? So this is 6A, but you have to see that video. I'm not giving too much information about that one because I want my dear doctor to search in YouTube about ankylosing spondylitis and type my name. Ankylosing spondylitis, and you have to type my name, Shari Ahmed. You will find it in YouTube so easily, that video. Now, in case of about ankylosing spondylitis, let me give you another slide that would be useful for many of you. Yes, is this one. Often, they will give you clinical scenario and they will ask you investigation and they will ask you treatment. About investigation, it's often comes with back pain. It is true. The young age, middle age man comes with back pain and arthritis problem, maybe eye problem. It's ankylosing spondylitis often. So you like to do X-ray. After X-ray HLA-B27. I repeat, after X-ray HLA-B27. Finally, you can go for MRI. So here it is given X-ray is the initial. In between there is a HLA-B27, and finally there is MRI to confirm it. Clear? X-ray, HLA, then MRI. Next, often treatment task. They give you a scenario and they'll ask you treatment. So exercise program and NSAID are the best. One time they also ask, okay, NSAIDs are no more useful. I repeat, NSAIDs are no more that useful. They were telling like that. So that time your answer would be infliximab. This is taken from Master the Board, this slide. So you can rely on that one. So if NSAID not working, you can directly go for the infliximab in case of ankylosing spondylitis. I was not supposed to say this information. You are supposed to find it out from the YouTube. Okay, so I hope so you know my YouTube channel. That one, sometime you guys should see those videos you like. You should hit some like. Okay, so push those YouTube videos to more other people's timeline. I hope so you can do that actually. There's a few things about ankylosing. As I said, ankylosing I'm telling a little less because I want you guys to find it out from the YouTube. Very easy how to find it. I'm telling you. You go to YouTube, open your own YouTube, then go to search option and search with ankylosing spondylitis and just type my name. All right, then give enter. I have to tell him that way because a lot of doctors got confused often. All right, I hope so. Some of you, I mean, those are first already have seen it already, I guess. Okay, so are we done with the seronegatives? Are we confident about seronegative? Please let me know in the. So we are at the almost end. We have a one major one that's coming up. That is the big one that uh, rheumatoid arthritis actually. So I have to give you few, straightforward information about rheumatoid arthritis. But before that, can we take just maybe 3 minute break? I just need to break, guys. So maybe 3-4 minutes, very short one. I'll be just coming in maybe 4 minutes. Yeah. So we'll be back in just 4 minutes. Thank you. All right, everyone. So I'm back again. So how you guys are available now? Yes, I'm sure you do. Sorry for keeping you wait. Okay, so thank you so much for your attention. So we'll be sharing that one for rheumatoid arthritis, a very popular topic, or seropositive, the one we're talking about, the seropositive. Actually, that's the only thing that was left, and osteo actually together. Osteo is very easy, by the way, guys. Before getting into rheumatoid arthritis, osteoarthritis is given, I think, better in in 168 page. For osteoarthritis, you imagine your grandparents, or if you have some patients who has pain in multiple parts of the joint, most of them are degenerative. And one interesting question about that, as the day progresses, what do you think? The pain increases? Or if they walk more, is the pain increases or decreases? This is one of the popular question. So I just highlight it at the end. Worsen with movement, improves with rest. So worsen with movement, improves with rest. So this is for osteoarthritis. Also a popular word, some good days and some bad days. Have you heard this like term like before? Some good days, some bad days, and that is applicable for osteoarthritis. Okay, so since there are some good days and the bad days, and your bad days definitely need some treatment. So what is the treatment basically? So basic treatment is an analgesic, and many times you'll see they have weight and you ask them to lose some weight. And at the same time, earlier I asked you guys, there is something for the joint, not evidence based, like modestly effective, they said. So glycosaminoglycan. Those, I mean, things are not controlled with simple drugs. For them, injection corticosteroid. I'm sure you've heard of that. Have you ever heard that for osteoarthritis, they need hip replacement surgery? Have you ever heard this while you have placement in orthopedics in past? I mean, that's of course not the common thing. That's less common, and but there are some cases where it's so severe, the pain and stiffness, that you have to go for surgery. Yes. Oh, also assisted. That's nice actually. So the hip replacement surgery because of the severe osteoarthritis, severe pain. So you need surgery in those cases. Up to surgery, it won't come. So these are the basic things. I mean, initially analgesic and the things. How to make a diagnosis? Very simple. By X-ray is more than enough. X-ray and clinically more than enough to make a diagnosis of osteoarthritis. Osteoarthritis comes very less in AMC, by the way. The one that comes more is gout, rheumatoid arthritis. Okay, so these things comes more in your AMC exam. Some vasculitis like giant cell arteries comes more often. Those are also quite important topic. Apart from that one, the antibody related things comes, Raynaud's things comes, okay, septic arthritis things that do come. Okay, so septic arthritis, if one single joint often affected, that is, and pain and fever, single joint affected and pain and fever, that is septic arthritis until proven otherwise, right? And if it is said multiple joints, that's almost always it's either rheumatoid or osteo or so on. Actually, if it is monoarthritis or single joint involvement, it can be um, either gout, or you have to find out pseudogout or traumatic. I hope so. The conception is clear. So polyarthritis, monoarthritis, if uh, single unilateral affected and pain fever, then we suspect septic arthritis. And if it is septic arthritis, we go for antibiotic or arthrocentesis, guys. Come on. For septic arthritis, what is the next step of management? Very popular question. So answer is arthrocentesis or antibiotic. Answer is arthrocentesis. Okay, means joint fluid aspiration. Arthrocentesis means joint fluid aspiration. That is the thing. Okay, now last topic is actually the rheumatoid arthritis. I'll open a file for that. Just give me a second. We're almost done. Don't worry. I'll take 5 to 10 more minutes. We'll be done. Okay, going to share the file now. All right, going to. So we'll start with a question just to test your knowledge. All right. So in this question, if you see someone who is elderly and rheumatoid arthritis known case and having worsening of right wrist, diagnosed with, so known case of rheumatoid arthritis, pain, knee, these are affected. So polyarthritis. Medication involves methotrexate, naproxen, and all these things, right? And now on examination, these are the vitals given. You can check for a while the vitals. And on examination, tender, swollen joint actually, and right wrist is warm to touch. Right wrist warm to touch. So known case of rheumatoid arthritis, and also pain has increased recently. So which of the following is your appropriate management? I mean, new doctors, please try attempting this one. We know for rheumatoid arthritis, methotrexate is one of those very common treatment. Well, let's see what you guys are thinking here. Okay, so since you guys got it, that single most joint that is been involved, single most joint that is involved, and previously, I mean, very good, I'm very happy at the end. So, and previously damaged joint has chances of developed pseudogout and also septic arthritis. So that is the reason this is not actually flaring up of rheumatoid arthritis. This is actually septic arthritis, already damaged joint by rheumatoid arthritis, and now one particular joint involvement. If it is rheumatoid arthritis, multiple joint will be involved. So single joint involvement in a previously damaged joint. So this is septic arthritis. So patient has sign symptom of septic arthritis. So our answer is E. Those of you who have answered E are correct actually. Clear guys? I hope so. The answer is clear. So your probable diagnosis septic arthritis following rheumatoid arthritis. Very tricky, very tricky. Now, few questions are answered. Most common clinical presentation according to John Murtagh. It is actually arthritis. That is the most common clinical presentation of rheumatoid arthritis. Then goes morning stiffness, then rheumatoid nodule. These lines are given in John Murtagh as well. Okay. Which joint is most affected? Knee joint is something mostly affected according to John Murtagh. What is the initial test? I hope so you guys are writing. I hope so you guys are writing this. What is the initial investigation? Initial investigation is rheumatoid arthritis test, RA test. How to confirm rheumatoid arthritis? This is a MBBS level topic. How to confirm rheumatoid arthritis? Answer is anti-CCP antibody. Okay. What is the initial treatment for rheumatoid arthritis? Now, this is a confusion. Many doctors answer DMARDs. Is disease-modifying anti-rheumatoid drug is a treatment for rheumatoid arthritis? Initial treatment is of rheumatoid arthritis is DMARDs. What do you think? No, answer is no. It's NSAIDs. If they ask best treatment to prevent progression of rheumatoid arthritis, now this is how the question should be: best treatment, or they will ask you name a drug that will prevent disease progression. Then your answer will be MTX or DMARDs. You got the difference, guys? This is the difference. Best treatment, or they might ask separately, prevent progression of rheumatoid arthritis. That is DMARDs. Now, one important question, that is, NSAIDs do not prevent rheumatoid arthritis progression. Some doctors has a lot of confusion on that one, especially with this term. Doctor, isn't it a steroid? No, it's not. You need disease-modifying anti-rheumatoid drug to prevent or halt the disease progression. How, cause of death? Heart disease. In case of SLE, what is the cause of death? again heart disease. But in case of young, it can be renal problem too. Okay. If methotrexate fails in rheumatoid arthritis, what options you have? Methotrexate itself is a very powerful drug, but some cases it does fail. Then infliximab or rituximab, infliximab or rituximab in that case. Next thing that is coming, which drugs for rheumatoid arthritis safe in pregnancy or rheumatoid arthritis and pregnancy case? Now question is, can we continue sulfasalazine? Rheumatoid arthritis and pregnancy. Okay, what is normal treatment of rheumatoid arthritis? We start with sulfasalazine, methotrexate. If it's not working, we go with infliximab or rituximab. Okay, so in pregnancy, what is your option? So in pregnancy cases, sulfasalazine still it's safe. What do you think? For female, sulfasalazine is safe. Now, there can be an interesting question. A male with rheumatoid arthritis planning to take kid with his wife, of course, and he is on sulfasalazine. Should he continue the same drug or should he stop it? Now, that can be the question. So for him, he should not continue because why? Because the reason behind that one is sulfasalazine causes azoospermia or low sperm count. So now I would like to give you a chart on DMARDs, which can be very useful for you. This is taken from Davidson's medicine. Please take a picture for this one. Later, please read this one, especially the drug name, what you like to monitor, this thing, and the side effect. Okay, these things, please memorize it. Methotrexate, sulfasalazine, hydroxychloroquine. Hydroxychloroquine can cause eye problem too, retinopathy. Please remember it. Cyclosporine can cause kidney problem. Okay, they test side effects here. They test, what to test. For example, there was a question with methotrexate. Before giving methotrexate, what to take? I mean, what you like to test? Liver function test. Okay, methotrexate, it was liver function. No, those never asked. I like to repeat one more time, guys. Those they never ask in AMC. Okay, so here they usually ask you like, which one you like to start as a drug, what to monitor. Sulfasalazine, what to monitor? We monitor CBC. In sulfasalazine, we monitor CBC. And in case of male, sperm count, and these are important as well. And if it's male going to take the baby along with his wife, they need to stop it. The male need to stop it. Female does not need to stop sulfasalazine. Clear, guys? I hope so it is clear. I'm trying to be giving more precise information. This one, please take a picture. I mean, this will be useful. This one can be very useful for you. These drugs can be used during pregnancy. These are to be avoided. So methotrexate can we use? Of course, no. I mean, this everyone knows that methotrexate something to be avoided. We all know that. One more interesting question I like to finish with, and that one is, before going for rheumatoid arthritis, I mean, a person who is having rheumatoid arthritis and going for any surgery, what test you want to do along with the other common preoperative test? Along with all preoperative test, one special single test. So well done, well done. You have read Davidson well, I guess. So this is cervical spine X-ray. Why? Its reason is there is a word subluxation. Atlantoaxial subluxation can be underlined. So normally what do you see? The anesthesiologist, they extend the neck. So if you have subluxation and your anesthesiologist will extend the neck, that can be catastrophic. Okay, so please understand it. We don't need this X-ray. I mean, just for showing purpose, I'm showing it. If there is subluxation things, I mean, it can be very dangerous in that case. So this is something we tested. And of course, synovial fluid analysis, I mean, you can keep it in mind, that's up to you. but septic has a lot of WBC count. Rheumatoid arthritic has relevant count, but septic has the highest WBC count. All right. We already told you the treatment, NSAIDs being the number one, and you need to use the DMARDs. And for chart of DMARDs, don't follow this one. Follow, yeah, this one. Okay. Like say, I like to cover things in that way. You don't have to open too many things. Okay, so sometimes it takes a little bit more time, but more than you, I become more tired actually. Okay, so because I have to keep talking for a long time actually, but I'm used to with these things. You guys also need to get used to. One more thing, do you know why my students does very well? Because my classes are 3 hours and 3.5 hours. So everyone get used to with the things because your exam is also 3.5 hours, isn't it? So 3 hour to 3.5 hours, it also takes to finish that exam. So you will have that habituation at the end. When you go to exam hall, you will not get tired much actually, especially if you attend my class. Okay, so that's okay. I mean, never mind. And lastly, finish with this is X-ray of what? This is a normal hand, and this is I can see a Z deformity, isn't it? This is rheumatoid arthritis. Rheumatoid arthritis. We have a very interesting last one X-ray of osteoarthritis. Just to remember, loss. L starting with loss of joint space, and that is the reason we give glycosaminoglycan to increase the fluid. Joint space will be more in that case. Sclerosis, cyst. So in short, loss. Osteoarthritis, loss. Of course, there's a lot of joint movement loss. So technically, you can remember loss. Now, I remember in my FCPS, this question came even rheumatoid arthritis. That time I didn't know what is the finding of rheumatoid arthritis X-ray finding. Actually, finding is juxta-articular osteopenia. I think many of you also don't know actually that one, especially fresh graduate actually. So juxta-articular osteopenia to remember. This is osteopenia. Okay, they won't ask you to interpret the X-ray in that way always. Okay, not this X-rays actually. They'll tell you most cases the finding. And of course, loss of joint space. One of those X-ray of the joint will not require joint space loss, like normal joint space, and that is gout. Gout does not have loss of joint space, it's a normal joint space, but there is erosion. It's the erosive disease, right? Joint destruction. Joint destruction is common in gout. What do you think? I think yes. All right. So I think it's a little long, but that's okay, guys. I mean, so things I just have covered, you can see in rheumatoid arthritis. You can also check it. Yes. Some of this rheumatoid arthritis thing. I hope so you guys will enjoy overall. Rheumatoid arthritis also given in page number is given here 374. So basically I have wrote the thing I told in the class. You guys have taken note, try to follow that one mostly. You'll not find that organized in John Murtagh. Sign, symptom things are given, investigations given, which I already told. And finally, the management. Management initially is analgesic or any painkiller, and eventually you have to give disease modifying anti-rheumatoid drug. And I just like to finish with this table. This one everyone knows from their MBBS, I'm sure. There are like 7 or 8 criteria for rheumatoid arthritis. Do I have to tell that one? I mean, what is that 7 criteria of rheumatoid arthritis? I think this one everyone knows. I mean, morning stiffness, then arthritis, RA positive, right? So this is some of those criteria. Like one thing I just can highlight here, that is morning stiffness is more than 1 hour. Morning stiffness is, around 30 minutes in case of, please write note here, morning stiffness is like 30 minutes. This is page number 376, guys. Morning stiffness is around 30 minutes for ankylosing spondylitis. Morning stiffness is 5 minutes in case of osteoarthritis. So rheumatoid arthritis more than 1 hour, around 30 minutes, it's like ankylosing spondylitis, around just 5 minutes for osteoarthritis. And as the morning, it's more pain. As the day progresses, it's less pain in rheumatoid arthritis. I hope so all of you know that. Day progresses, pain less, rheumatoid arthritis. Day progresses, pain more in osteoarthritis. So I think it's a little long class, but I hope so you enjoyed today's class. I mean, it's might be a little different from the authentic medical lectures. I hope so you guys enjoyed so far. Yes, and wish all of you all good luck with the rheumatology, and you guys can go, and I mean I have already uploaded the exam question. You guys can go and take that exam after 5-10 minutes if you want, or can take tomorrow. Make sure you finish your exam things by tomorrow. Thank you so much. Sorry, I mean I don't tell those things, okay? And this is not a, I mean, yeah, exam you don't have to worry. I mean your study that matters actually. These exams where I take is just for self-assessment, so don't worry. You know, most of our exams are either 10 question or 12 question or 13 question. It's not like that. Okay, those not necessary to tell actually. When you go and just check, you'll find it out. Yeah, few things like just keep it as a secret. Everything if I tell, yeah. So because at the end it was a little tiring, but I hope so you liked. It's one of my signature lecture. Everyone say, Rheumatoid, you have also gone through your lecturers. I mean, in your medical college, some senior professors. So you better compare with that one. Actually, it will be better. Okay, then you can understand. I mean, was it good or bad actually? And I have to cover everything in a single class. Many professors used to come to class, and with many lecture they used to give actually just on single thing actually. So, I mean, good luck to all of you, and you need to study more. I mean, to catch up everything, you need to study more. Yes, I mean that I'm sure you will do better in coming days, and you all will be all right. And as I said, just follow week in the same way. You can appear in the exam in proper time, and you can actually pass. I mean, we have 95% passing rate, but some doctor appeared early, some doctor appeared late. I want you to be the early doctors to finish the MC. That's the thing. So that note, thank you so much to Dr. Sjögren.